Okay. Any questions about yesterday's lecture? Or anything else related to the class? Okay. Good evening, good evening. Hello. Okay. So then,
Good evening.
hi, how you doing?
Hi, good evening.
Hello, good evening.
Good.
Okay. So any questions about yesterday's topics or any other questions related to the class? Okay, so we're covering still vital signs and measurements. So we are going to continue with that part. So remember, just to make a little recap, we talk about checking measurements, weight and height for adults, weight, height, head circumference, chest circumference for infants or newborns. Remember that these measurements for newborns and infants are a must. So if you're working with a pediatrician or you're working with a family practice medical provider, probably you're going to encounter this because remember, family medical providers, they see babies from birth to the elderly. And if it is a pediatrician, well, you're going to be seeing the little kids mostly. So that's basically what it is. So we talk about that not to mix up vital signs and measurements. Remember, vital signs are something that has to do with living organisms. That's how we know if they are doing well or not. Weight and height are measurements. We can measure the height of anything. We can measure the weight of anything. So, but you know, certain objects they are not living organisms. So for that reason, we definitely need to understand the difference between them. Okay, so let's go back to whatever we left off, which is sites when we can check the pulse. Remember, it's very important because there are some questions here for national certification. So here we are. So let's go back again. We start from top to bottom, from the head all the way to the feet. So that's basically what it is. So we're going to start with one vital sign, which is usually, well, we can check pulse right here, but it's also used to check temperature. So remember, whenever you encounter these questions on your exam, because that will be the part that you need to use this, it will be this one, the temporal or the temporal artery. Remember, the temporal artery runs on the sides, right? And the side, at each side. So when we run the thermometer, we got kind of rubbing again, starting in the forehead in the middle, and then we run it to the left side. That's how we check temperature. That is the temporal temperature. So don't forget that because it's very important for exams. And just in case someone asks you to do the temperature, you can actually do the temperature in this area on the frontal part, mostly on the side. Let's talk about the carotid artery. Very, very important artery. Remember, it is right here in both sides of the neck. And that is the major blood vessel that brings blood all the way to the brain. So that's basically what it is. So it's a very, very important artery. And because it brings blood to the brain, when someone is having a heart attack, this is the point where we are going to check pulse. Because any other pulse when you collapse are not going to be felt. Because remember, your heart stops beating, you collapse. So for that reason, we cannot check the radial pulse all the way on the distal part of the arm, close to the wrist. We cannot check the apical pulse, which is the next one, which is located at the heart. So for that reason, we're gonna use this one right here it is. So if you put your fingers, 2 fingers, remember index and the middle finger right here in this area, turning your head a little bit, and you press very nicely and firm, you're gonna feel your pulse. So remember, this carotid artery pulse is felt when someone, or it is checked when someone has a heart attack, because that's the indication that if we don't have the carotid pulse is not felt or it is very faint, we have to start doing CPR, cardiopulmonary resuscitation. So basically that's what it is. So CPR, you use this particular artery to check for pulse. So usually we check like for 10 seconds, that is it. And we can count right there and we see whether the rhythm or the rate are normal if felt. Of course, if you collapse, it's not gonna be normal. That's the reason why we check it. So very important sites for checking the pulse, once again, due to the fact that, your medical assistant will be asked during national certification. Let's talk about the apical pulse. Apical comes from apex. Apex is the bottom part of the heart. This part right here, the bottom part of the heart, that is considered the left ventricle. And the left ventricle is the one that does most of the work. In other words, the left ventricle is the one that pumps blood to the head, all the way down to the distal part of the fingers, to the distal part of the toes. So can you imagine how hard this particular chamber works within the heart? Because it has to, pump blood to the head. The head very close. What about the fingers? What about pumping blood all the way down to the toes? That is a long way right here to send blood right here and then back. Right here and then back and to the fingers, the arms, everything, and to the head. So the heart does a lot of work. So this left side of the heart, which is called the ventricles, are the ones that pumps blood out the heart to the brain and to the rest of the body. So for that reason, we have this particular side right here on the left ventricle or the left side of the heart when we place the stethoscope. So here we are going to listen to the heart sounds. So usually we do it with patients who are elderly, that the heart doesn't function much, with the little babies. And if we don't feel the pulse, then we have to go right here to the apex. So that's basically what it is. So the apical comes from apex because it's the point of maximal impulses, PMI, which is the left side of the heart, one of the ventricles. So that's basically what it is. So you do not have to check the apical pulse. As a medical assistant, you don't do that. But if you've been asked, particularly during exam, which is the side of the body where you're going to be checking for the apical pulse, that's going to be the heart. So that's basically what it is. The heart, left side. And if they ask you, how are you going to check the apical pulse, you're going to be using a stethoscope. This is the instrument that is used to listen to the heart sounds. So that's basically how it works. Any questions about the temporal artery, the carotid artery, or the apical pulse? Because we're moving on. Okay, so let's talk about the brachial artery. Now, the brachial artery is very, very important when we do vital signs, particularly. So we use this because we are going to apply the blood pressure cuff right here on the upper arm above the elbow. That's when we are going to apply the blood pressure cuff, which is this bag that you kind of roll around the patient's arm when you are going to check blood pressure. So it is capturing the brachial artery pulse. That's when we check it. So that is important. That's for anyone when we do blood pressure, because we do blood pressure for children above 2-3 years of age. So that's basically what it is. We don't do blood pressure for the infants or for the newborns. Usually we don't. We listen to the heart on the apical part, which is here. So remember, the brachial artery is the artery that we're going to use to check blood pressure in either arm. Can be right here, or it can be in the other one, right or left arm. We will practice that when we get back to school. Another reason why the brachial artery is important is not because we are going to be checking blood pressure, but we also are going to use the brachial artery for children when we're going to check the pulse. So remember, yesterday we said pulse in adults, we're going to check it right here by the radial pulse, which is here. See the radial. The radial artery right here before we reach the wrist by the thumb side. That's when we're going to check the radial pulse for adults. But for children, where are we going to be using? We're going to use the brachial artery or either arm. We don't have to select this particular arm. It can be the right or the left arm. So you see the brachial artery has two services, you might say, or you're gonna utilize the brachial artery for two reasons. One, to check blood pressure for anyone. The other one, we're gonna be checking the pulse for children, remember. So that's basically what it is. So that is what is important about the brachial artery. Gracias. So that's how it works. Now remember, we talk about the radial artery because the radial artery is the one that we're going to be using to check pulse for adults. So that's basically how it works. Very simple. Remember, these are questions for exam. For that reason, I spend some time going over with this slowly and kind of repeating these several times. And most importantly, besides, passing the exam, is that you have to do it. Because you have to check the pulse from adults, you have to check pulse from children. If you work with children, so you're gonna use for adults the radial pulse, which we covered yesterday, which is right here, this area, or you're gonna do the brachial, which is a little above the elbow in the internal part of the arm. I will show you how it is captured, how it is done when we get back to school. But for now, I just want you to remember these particular pulses from the arms, because remember, this is within the arms. So the brachial for blood pressure, regardless of age of the patient, and brachial for children, pulse to check the pulse, and the radial to check the pulse for adults only. So that's basically what it is. And remember, it's not just knowing that the rate is the radial artery or the radial pulse, that what you're going to be checking. You need to know where it's located. Remember, it's on the outer side of the arm, lining up or on line with, in line with the thumb. So that's basically what it is, because they're going to give you this information. Or you have to read the question and then respond the answer that tells you that these are the guidelines for you to check. So make sure that you don't forget this. So remember, important for you, the carotid artery, because during CPR, that's the one that you're going to check the pulse. The brachial artery, you don't use the apical. You do not use the apical to check pulses. You do not use the temporal to check pulses. The temporal is important, and I refer to it when I said you can check temperature. If you check the temperature on the frontal area, particularly going towards one of the sides, is called the temporal temperature. That's basically what it is. So this is the only exception, that these temporal artery is used not for the pulse for you as a medical assistant, but instead to check temperature. So that's basically what it is. So don't get it mixed up. Then we're gonna move to the femoral artery. Now, what is the femoral artery? The femoral artery, remember, this is the bone right here, the upper leg. This is the upper leg. So this is the bone that, goes underneath here that makes the upper leg, is called the femur. And right next to it, we're going to have the femoral artery. So that's basically what it is. So when we're going to check the femoral artery, usually we check it in between the crease of the inguinal area, right here, where the inguinal area splits the two legs, one to the right, one to the left. We place our fingers, these fingers right there. It's like here, this is the leg, and we place the fingers right there. And that's how you're gonna check the femoral pulse. Now, this is something that medical assistants don't do. You do not use the femoral pulse. This is for medical doctors. But unfortunately, during exams, they're gonna ask you where it's located. So the femoral, I remember, the femoral artery comes right here splits from the aorta. So because all of this down here is the aorta, the splits in the femoral right and left. So that's basically what it is. So they want to know what it is. So it says right here by the groin area where your legs kind of attach to your hips. That is when you are going to be checking the pulse for this particular site. Now, once again, this is the job of the medical doctors, but you need to know where these pulses are. Next, we're gonna have here the popliteal pulse, because this is the popliteal artery. So once again, pay attention to this because these questions comes out in exams. So the way that they are stated or they question you is where is the popliteal pulse located? So you're gonna say right there behind the knee. Right behind the knee, you're gonna find the popliteal artery. It's not in front. Here we are seeing the anterior part of the body, but the popliteal is gonna be felt on the back of the knee. So just remember popliteal is an artery behind the knee. That's basically how it works. These are pulses that only the medical doctors check. They need to know whether the blood is flowing normally all the way to the toes. That's basically how it is. So when the patient complains that the legs goes numb, or that you have kind of your leg kind of goes sleep, so then probably you don't have enough circulation, and for that reason we check these pulses from the hips down. That's basically that, the femoral and the popliteal. Now we're gonna have the last one, the dorsos. Well, this is not the last one, there are others, but this is the one that we have here, the dorsalis pedis. Dorsalis means the dorsal, the foot, which is the front, the upper part. This is the dorsal. Pedis means foot. So this is the dorsalis pedis, is located right there in between the big toe and the fourth toe. That's basically what it is. So we place our fingers right there close where the toe and the forefinger splits, and you place your fingers like this. And then here you are in this area. You're gonna find the pulse. Now, once again, you don't have to do that, but you need to know where it's located. So just for you to know. Now, the ones that you have to use, remember the carotid in emergency situations where the patient is having a heart attack, the brachial artery to check blood pressure for any age, except the little babies, and for children pulse, that's what I'm gonna check. Then we go for the radial. Remember the radial adults check pulse over there. So that's basically what you need to understand. So remember that we have been spoken about all these sites and vital signs and how and where should be checked or capture these vital signs in the patients, particularly the pulse right now. So that's basically what you have to pay attention. Even though if you never give CPR or encounter one of the situation, it doesn't matter. The exam requires that, so you gotta keep it in mind. Any questions about this pulse size? Remember, we need to know exactly what is the site of these pulses, because other than that, we're gonna be kind of lost when somebody asks. So always use this table as a reference, so you know exactly where the pulses are. There are other pulses, we don't use it much, but again, these are the most common pulses, particularly the ones that you're probably going to be involved. Some of them you will, some of them questions on the exam, you need to know them. Okay, moving on. Let's talk about the characteristics of pulse. So pulse have two major characteristics. One is called rate. One is called a rate, and the other one is called a rhythm. In very simple terms, the pulse is the number of heartbeats per minute. That is it. That is pulse rate, because make the pulse while we're checking the rate. But we're also checking the rhythm. Why? Because the rhythm has to do with the time from one beat to the next beat. In a normal, regular, heart rhythm, these heartbeats needs to be at the same time and distance. So when you check the pulse of someone, so you can try yourself, put your two fingers right here by this radial pulse, and you feel your pulse, and your pulse goes like boom, boom, boom. So it's at the same intervals, at the same distance. The first beat, the second beat, the third beat, all of them are gradually regular. So that is called regular. So let's say right here starts the first beat, then you go here, the second beat's here, then you go here, the third beat, and the 4, and the 5, and the 6, and the 7, all the distance between here and here, between here and here, here and here, are the same. That is called a regular rhythm. So rhythm has to do with the distance from one beat to the next. Whereas rate is how many times your heart beats per minute. See the difference? So when we get back to the school and when we get to CPR, not CPR, electrocardiography or EKG, then we're going to check our pulse, and then we're going to see whether it's regular or irregular, whether you have a normal heart rate, 60 to 100 beats per minute, or whether your heart is beating faster than that. So then you will have tachycardia, or whether your pulse rate is lower than 60. Now you have bradycardia. So that's basically what we need to understand, because this is very important. If you check the pulse from a patient who is supposed to have 60 to 100 beats per minute and they have more than 100, well, unless it is something physical, some activities, remember, because activities kind of changes how your heart beats, how fast, how slow it is. See, if you check my heart rate right now, I'm sitting right here and I'm talking, that is it. My heart rate should be in between 60 to 100 beats per minute. But if I'm nervous or I'm running or I'm stressed out or angry, well, my heart is gonna be going faster. Think about that. That's logic. Or if you have a medical condition, then your heart is going to be fast. And it turns out that you're just sitting there, you're not doing much. And you're not stressed out, you're not sick or anything like that from anything else. Remember, when you're sick, your heart rate goes up, your respiratory rate goes up, your pulse rate goes up. So once again, things change, and that's what we need to figure it out, whether you have a medical condition or it is something external or something emotional or it is something psychological. Remember, once again, the reason why we shouldn't be telling the patient the results is because any of these situations can happen when you tell the patient, wow, you are tachycardic. Wow, your heart rate is so fast. Then it turns out that the patient is having an emotional situation. Patient is going through divorce. Are you sick? You're not sick. This is emotional. You just lost your job. Oh, you're sick. No, that is emotional. But you don't know because you're just been checking the patient vital signs. You're getting just numbers. So that's basically what it is. Can you hold on a minute? It's raining super heavily and I have all my windows open and I don't want water to come out inside my home. Just give me a second, please. Okay, I'm back. Done. I have like 20 windows in my home, but I don't have to close all of them. It's just a couple of them that I have around here, and I don't have the person who do the maintenance right here, right now. Okay, so that's basically what it is. So once again, we're talking about rate and rhythm. And most importantly, you know, just for the rate, you're not gonna be asked about rhythm. You're gonna be asked about rate. And remember, when the question that you're gonna have always is because very simple. It is, what is the normal heart rate for an adult? 60 to 100 beats per minute. So they're not gonna ask you directly, like for instance, if the patient has the heart rate more than 100, what is called? No. They're gonna give you numbers. Since you know which are the ranges from normal, you should be able to get the answers from there. So let's say, for instance, they're gonna give you like, you have a patient, it is 42 years old, you immediately know this is an adult. This is a 40 years old male, and you were checking the pulse, and the pulse is 120 milligrams mercury, I'm sorry. It's HMG, milligrams of mercury. So then immediately you should be thinking, wow, this is more than 100. So what is the problem? The patient has tachycardia. That is it. They're not going to tell you the patient was running, the patient was upset. No, nothing. This is not to diagnose. This is just to know if you know what are the normal ranges of heart rate. That is basically what it is. Or they can tell you that you have a female who is 55 years old and she has a heart rate of, let's say, 50 milligrams of mercury. So immediately you go like, oh, wait a minute, 50 is less than 60. So it's lower. So for that reason, this person has bradycardia. That's how it's done. It's not like straightforward. Oh, it's more than 60 or less than 60. What is it? It is more than 100. What is it? Not like that. Remember, they're going to give you a little scenario with the patient. You're the medical assistant. You're doing the heart rate and you check the heart rate on this particular patient. And this is the result that you get. So what is it that the patient has? Now, usually is tachycardia or bradycardia. They're not gonna give you normal values. It's, no, it is normal. No, they wanna know what is it, because the other question is gonna be what is the normal rate. So then you have to know that it's between 60 and 100 beats per minute. So that's basically what it is. So remember, the rhythm mostly applies also for pulse and heart rate, particularly when we are evaluating the patient for any medical condition, any arrhythmias. See, arrhythmia, meaning it is not normal. Arrhythmia, oh, rhythm is, the intervals in between each heartbeat. So the time from one heartbeat to the next. But when you have an arrhythmia, means your heartbeats are not standardized. It's like not at the same time. So remember, if it is regular, it goes from here to here, and then the next one from here to here, and from here to here. And if you measure the distance here, 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 is equal. So that will be regular. But if it is irregular, now your heartbeat goes like this. This is one beat, this is another one beat, this is another one, this is another one. There is all over the place. So one heartbeat is here, then the other one is like disappear and then come back, and then you say, oh, wait a minute, something is wrong with me, not with you. The patient is having problems. So when we are going to practice this heart rate, you're going to see probably most of us are going to be, regular, because to be regular, you have to have a medical condition, a cardiovascular condition. Other than that, no, because it can be fast, but at the same time, it's fast, but regular. So that's basically what it is. Now, what is important to know what is regular or irregular? Because when you check in the pulse, remember, we have to check for a period of 1 minute or for 30 seconds and multiply it by 2. But when someone has an irregular heartbeat, you cannot do that. You have to check for the entire minute. Why? Because it's irregular. When it's regular, you get, let's put it this way. You're my student. Every single time that I give you an exam, you get 199, 199, 198. So that is very regular. But if you get like 40, then the other one 60, then the other one 90, then the other one 20, and that's not regular. That is how happens with the heart rhythm. Then it's irregular, so you're not regular. You're not getting the same grades all the time. One, you get this very low one, then like in the middle, then very high, then go back to the middle and low, and well, that's not regular. So how can I give you one grade out of those grades that you have? I can do that. So I have to add them up and get an average. The other ones, no, because if I see that it's regular, I can pick anyone. That's where I can count to 30 seconds and multiply by 2. The other one, you have to go all the way, count the minute. Otherwise, you're going to miss the heartbeats from this patient. You're going to get wrong results. So that's basically how it works. Okay, any questions about pulse? Particularly heart rates and rhythm. Now, you will not be asked about the rhythm. You're going to be asked about the rate. But I want you to know about the rhythm, because when you have your patient and you're going to check the pulse, and if you kind of go to just 30 seconds and multiply by 2, and this patient has an irregular rhythm, all the information that you got is wrong. It's wrong because the only way that I can check for 30 seconds and multiply by 2 is if the patient has a regular rhythm. Irregular rhythms, you have to check for the whole period of 1 minute or 60 seconds. Okay. Any questions about the characteristics of pulse, rate, and rhythm? We will repeat this back again during electrocardiography, but once again, I want you to start getting, familiar with these terms. I cannot stress enough, my students, you are not going to learn all these at one shot. When we practice, and only when you start practicing, you're going to understand all this. Other than that, it's like monkey see, monkey do. You're just gonna pretend that you do something, but you actually do not know what you're doing and what you're getting all these results. So I want you to little by little, trying to absorb some of the information. And then when we get to the practical part, then you're going to put it to practice. Then you're going to get better understanding. That's the only time when you practice. Other than that, it's like just information in your head. But when you practice, stays. And you know it because you have to do it several times. Oh, well, you have to do it all the time when you are at work. So that's basically how it works. All right, moving on. So it says right here, measuring the radial pulse. So we already did it. We checked the radial pulse. Remember, we watched the video. I think that we watched the video. Yeah, we did. And see, remember, this is for adults. So read the definition, because the definitions are very important when you are, taking an exam, and actually when you are practicing, because this is one of the vital signs that is one of the easiest, but you need to understand what you're doing. So what is the radial artery? Because it's not that it is the radial pulse. This is the radial artery. And when we apply pressure over the radial artery, we are going to capture the radial pulse. So remember, radial comes from the artery. The pulse is when we apply pressure over that. And when we apply pressure over the radial artery, what we do is we kind of blocking the flow. So the blood flow is kind of blocked. You don't press too hard. You just press very mildly. And then you start feeling the pulsations. And when you feel the pulsations, then that is it. You don't press much. And you don't release your fingers until you're done counting. Because other than that, if you release your fingers for any reason, you lose count, because then the pulsation is going to disappear. Because the pulsation is going to be felt because you're applying pressure over that radial artery. But as soon as you release it, gone. You're not gonna feel it anymore. So you're gonna be kind of lost. And you can get the, an accurate measurement. That's basically how it is. So where is exactly this artery located? Remember, it's located on the inner aspect of the wrist. So right close to the wrist where we bend the hand by the wrist, you kind of put two fingers right there, and then that is it. And remember that it's located alongside the thumb. So that is basically what it is. It's not by the pinky, because here there is another artery that's called the ulnar. We're not checking that because we don't have an ulnar pulse. We have a radial pulse, not an ulnar pulse. We can check pulses over there for other reasons, but not for the purpose of this class. So that's basically what it is. Or to check vital signs. So that's basically what it is. I believe that we did this yesterday, checking the pulse. So we are not going to do it again. I think that we did it, right? I don't know why this stuff is here, but that's how it is. We know how to check the pulse. Let's talk about apical pulse. Before we move to dive into this topic, any questions? Okay, so apical pulse, a little more details. Remember that I told you that the apical pulse is located at the point of maximal impulses, the PMI, which is right here at the tip of the heart. Remember, in this area, that is where we are going to check the apical pulse. Why? Because this is the left ventricle. See, this is the left ventricle. And here is when we are going to apply the stethoscope. I'm going to place the diaphragm of the stethoscope right here. And then you see it has this cord right here. And the person is going to be listening to, the heart beats right here on this end. So that is exactly where you are going to be placing the stethoscope. Let's go and be a little more precise, so to speak. So you see right here, you're going to use a stethoscope. You must know about the stethoscope because they're going to ask you not how you're going to check the apical pulse. No, when you're going to listen to the heart sounds, how are you going to do that? What instrument you're going to use? We're going to use a stethoscope. So that's basically what it is. And where are you going to place the stethoscope? Right here by the apex of the heart. That's what is called the apical pulse, because you are applying the stethoscope right there at the apex of the heart, which is the tip of the heart. The part when we have the highest beat of the heart. This is called the PMI, point of maximal impulses, because this is the left ventricle, and the left ventricle works harder than the other chambers of the heart, because once again, it's the one that has to pump blood to the head, to the tip of the fingers, and to the tip of the toes, and back. So I go back and circulate. So it's the long work that it has to do. So for that reason, it's very strong. The heart beats right here. So for that reason, we check this area, the apex. Now, where is the apex located? In between the fifth and the sixth intercostal space. So that's basically what it is. Well, it's not between the fifth and this is between the fifth and the sixth rib. That's basically what it is. Because right there in between the fifth and the sixth ribs is going to be a space that is called the fifth intercostal space. Once again, let's look right here. See, here are the spaces for the rib spaces. This is number one, rib number one. So this is one space. This is second space. This is the third space. This is the fourth space. And this is the fifth space. Now, again, these images are not accurate. So the tip of the heart should be here in this area. Oops. It should be here, the tip of the heart. But in this image, it's not accurate because the tip of the heart is located right here on the fourth intercostal, actually the fourth rib. So not good, but that is what I'm trying to tell you. So it will be the fifth intercostal space, not in between the fifth and the sixth rib, because, oh, in the sixth rib, not between the fifth and the sixth intercostal space. That's a totally different issue. So that's basically what it is. Now, fortunately, they're not gonna ask you that. So you're not gonna have to respond that this is in the fifth intercostal space, but if they ask you, that is the answer. Most of the time, they're just gonna ask you, where is the apical pulse located? The tip of the heart. It's the heart where you have to check. And what instrument you're gonna use for that? The stethoscope. So that's basically what it is. Those are the most important things. Now, heart sounds, we're not gonna discuss the heart sounds right now in detail because that will be part of EKG or electrocardiography. So the heart has two normal sounds, the lob and the dub. And that's basically what we do. When we count the heart sounds, we're listening to the two heart sounds when it closes the valves. So that's basically how it is. But we're not gonna get into details right here because that is not the purpose of this class, because you're gonna get a little confused. This will be explained better when we get to electrocardiography, because we have more information there, more details, because we are talking about the heart and the blood vessels only. This is just a procedure, how to check the apical pulse. So that's basically what it is. Okay, so once again, as you have seen previously, some of the videos are very short, very simple. So it looks like all the things that I'm been telling you are not there, but they are, because they are so fast, you just go and do it. But in between doing the procedure and all of the preparations to do it, all the steps are there. So that's basically what it is. Remember, every single procedure follows almost the same pattern, meaning, you have to introduce yourself, you have to greet your patient, you have to get the patient's identification, 2 points identification, full name, and date of birth. You can explain the patient what you're gonna do, because you're gonna get consent. When you tell the patient what is it that you're gonna do, actually you are asking for consent. We do not ask the patient directly, hi, I'm gonna do an EKG. Do you allow me to do it or not? No, that is not what is these explanations all about. No, we just tell them, hi, Mr. Mrs. Smith, the doctor ordered a blood work. I'm gonna be drawing your blood, okay? That's it. The patient just sit or say yes or whatever else. They don't even need to talk. They just stay there and they just pull their arm out. So you know already that they accept it. Because if they say no, then you're not gonna do it. So that's basically what it is, because we don't go against what the patient wishes are. But this is for the good of the patient, so usually they comply. But once again, we go through all this. It's just that some of the videos don't explain you all that, because it is assumed that that's how it works. So that's basically it. So just get the habit that every single time that a patient comes to you, even though if you're in the front or on the back, regardless, you meet them from the first time, you're gonna be greeting them all the time. Hi, how you doing? My name is Alberto. I'm the medical assistant. Well, how can I assist you? Oh, the doctor ordered this particular procedure. This is how the procedure is done. And you give all the recommendations. If there are more instructions, because the patient has to remove their clothes, what part of the clothes needs to be removed, you're gonna give them a gown and so on and so forth. Well, you're gonna go through all those things. Just because the videos that I show sometimes don't have all that information, does not imply that that's exactly how it's done. No, that goes directly to do the procedure. But before that, we have done lots of the preliminary assessments and interview and explanations to the patient, because we need to identify who are we going to do the procedure, what procedure is going to be done. We need to get the consent from them. We need to explain what is it to alleviate apprehension from the patients. If you don't tell the patient what is it that you're going to be doing, they're going to be wondering what this person going to do. Now, if I'm going to be checking vital signs, they're going to become very nervous. Now the vital signs shoots up. And now you think that the patient is sick. So you have to take in consideration many things. So be careful. This is done every single time. I got so used to that things just automatically comes out my mouth. As soon as I see the patient, I don't even think about it. Things just flow. Okay, assessing the apical pulse. So let me share the video with you. Okay, here it is.
After performing hand hygiene and ensuring privacy, introduce yourself to the patient. Then identify the patient using 2 identifiers.
Hi, Mr. Davis. I'm Nikki, and I'm going to be your nurse.
All right,
First off, I
Hi,
want to take a look at your
Professor.
hospital
I
ID
can't
bracelet,
see
okay?
anything.
all right.
All right. Can you tell me your name and date of birth?
Bill Davis, December 25th.
Someone asked me a question.
Yeah, I can see anything.
You cannot see anything.
Yeah, correct.
Okay, anybody else having a problem? Because I have my phone here on the side. I can see and I can hear. Anybody else having a problem?
It's the same here.
Can you guys see it? Someone is watching the video
no.
now?
No, I can't see anything.
Oh, well. Here we go again with these videos. Let me start all over again. Thank you for letting me know, because see, I don't want you to miss it. Okay, let's check this again. Well, you should be seeing, I see it right here. Okay, now.
After performing hand hygiene and ensuring privacy,
Yes.
introduce yourself to the patient. Then identify the patient using 2 identifiers.
Yes.
Okay, thank you.
Hi, Mr. Davis. I'm Nikki, and I'm going to be your nurse.
All right,
First off, I want to take a look at your hospital ID bracelet, okay?
all right.
All right. Can you tell me your name and date of birth?
Bill Davis, December 25th, 1929.
To take the apical pulse, begin by assessing for factors that can affect its rate and rhythm, such as medical history, disease, processes, age, exercise, position changes, medications, temperature, and sympathetic stimulation.
Okay, well, we're going to get started. I'm going to take a listen to your heart rate, okay?
All right.
So first
Clean
I'm just gonna
gloves are
lift
worn
the bed
only
up a
when the
little bit.
nurse may be in contact
I'm
with
just gonna
bodily
elevate your
fluids
head.
or the patient is in protective precautions. Help the patient into a supine or sitting position and expose his sternum and the left side of his chest. Now, locate the point of maximal impulse, or PMI, also known as the apical impulse. First, find the angle of Lewis, a bony prominence just below the suprasternal notch. Slide your fingers down each side of the angle to find the second intercostal space, or ICS. Then carefully move your fingers down the left side of the sternum to the fifth intercostal space and over to the left midclavicular line. When you've found the right spot, you'll feel the PMI as a light tap, about 1 to 2 centimeters in diameter, marking the
Excuse me,
apex
Professor.
of the
I
heart.
am not seeing anything. It's just still
If the PMI is not
frozen.
Okay. Who else
So-
cannot see or the video? Remember, sometimes if you're using a cellular phone, you have to put your phone or scroll all the way down or turn your phone horizontally. Sometimes, can you hear it? If you don't hear it, probably you don't have the video.
I'm hearing it. I can hear it.
So that is basically what it is. If you can hear it, that means that the little video in your cellular phone, if you're using your cellular phone, it is all the way down. So scroll down or place your phone horizontally and you're going to be able to see it, okay? Okay, so let me explain you right here. You don't have to do all of those things that this person is doing to find the fifth intercostal space. Don't. You're going to spend like half an hour doing that, and probably it's not going to be accurate. So check here, where is she placing the fingers? See? She's placing the fingers like 2 fingers below the nipples. So that is exactly where you have to place your stethoscope. So you see the nipples right here, place 2 fingers right here underneath the nipples, and wherever your 2 fingers end, then
Marking
it's
the
going to be the apex right here in this area. That's how I do it. I teach my students how to do things fast and accurate. This is something that, it's going to take you too long and you're going to get lost. How are you going to remember what is the notch? What is the first, second, third intercostal space following, the sternum? That is not going to happen. So it is very difficult when you try to check the intercostal space on someone who is overweight. You're not going to be able to find the spaces. You will never find it. So once again, follow these guidelines. Follow these key landmarks, the nipples. Right behind the knee, right underneath the nipple, put the fingers right there where the nipple is at and where your 2 fingers ends. That's where you're going to find this PMI or the apical pulse. So that is how I do it, and that's how I get it all the time, because it's a lot faster. Remember, you need to be fast, but you need to be accurate. The same we're gonna do when we start doing electrocardiography. Where are you gonna be placing one of the vectors, which is number 4? That is gonna be placed right here on the fifth intercostal space midclavicular line. So that is how you're gonna do it, right here below the nipples. And believe me, you will get it very easily. So that's basically what it is, including for females that has breasts. You just place it right there underneath the nipples, but right at the border of the crease of the lower part of the breast. That's it. Then you are in. So that's how it is. I will show you tricks how to do things right and fast, because like this, it's going to take too long for you to.
X of the heart. If the PMI is not where you expect it to be, as in a patient with an enlarged left ventricle, inch your fingers along the fifth intercostal space until you feel the PMI. Remember it's located at the left midclavicular line.
Okay, now that I found the spot, I'm going to go ahead and take a listen with my stethoscope here, okay?
Next, warm the diaphragm of the stethoscope in the palm of your hand for 5 to 10 seconds. Then clean it with alcohol and allow it to dry for 30 seconds. Place the warmed diaphragm of the stethoscope over the PMI and auscultate the normal S1 and S2 heart sounds, lub-dub, lub-dub. Once you can hear S1 and S2 with regularity, look at your watch. When the second hand reaches a number on the dial, or when the digital display reaches a round number, begin taking the apical pulse, counting the first beat you hear as 1. If the pulse is regular, count the rate for 30 seconds and multiply the total by 2. A normal heart rate ranges from 60 to 100 beats per minute. If the pulse is irregular or the patient takes a cardiovascular drug, count for a full 60 seconds. Also, listen for patterns of irregularity with any dysrhythmia. For example, you might notice that every third beat is skipped.
Okay, Mr. Davis, your heart rate is 64, which is good. It's within normal range.
Then replace
We're
the
gonna go ahead
patient's
and get you
gown and
dressed
bed
here.
linen, help him into a comfortable position, and discuss your findings if appropriate. Clean the earpieces and diaphragm of the stethoscope with an alcohol swab routinely after each use, and discard the swab in an appropriate receptacle. Perform hand hygiene. As part of your follow-up, compare the patient's pulse rate and rhythm with his baseline and with the acceptable range for his age.
Okay. So one of the things, that you have to take in consideration when I mention things, see, this is a nurse. It doesn't matter that it's a nurse. You're not a doctor. So still, you don't tell the patients. She did 2 things that are not correct. So the first thing was the patient is an admitted patient, right? The patient has a bracelet. And the nurse asked the patient's name. An inpatient, you do not ask names. You just check the bracelet to make sure that you have the right patient. That is it. That is first mistake. Second mistake, once again, is telling the patient, oh, your pulse is okay, or it is normal. This is this much. Anything, remember. Okay, so we're done. Thank you very much. So I will be seeing you later, Mr. and Mrs. Smith. That's it. You move on. If they ask you for the results, then you have an answer. The doctor is going to discuss this with you, Mr. and Mrs. Smith. That is it. Thank you very much. I will see you later. And you step out. You don't give an attitude. Not at all. So basically, that's how it works. So sometimes I have videos, that they show things that, you shouldn't be doing, but I'm telling you otherwise, like that, because I don't want you to make those mistakes. Okay, any questions? Okay, let's continue then with this chapter. So very good. So you don't have to explain every single detail to the patient. Remember, you're just going to tell the patient because this nurse was telling, oh, we're going to check this and we're going to check that. And no, you don't have to go through every single detail. Just going to be checking your pulse and the part of the chest. That's it. You don't even need to tell them the apical pulse because the patient do not understand. I'm just gonna be, listening to your heart. That is it. I know where my heart is. So you're gonna be listening with this machine, fine, or with this instrument. Not you just do the job because you have to tell them what they're doing. So don't give too much details to the patient because they don't need to know that much because they're gonna get confused and they're gonna have lots of questions for the doctor, and the doctor is gonna get very upset with you because you already gave information that the patient now is a little apprehensive and needs answers. So you don't want to cause that because remember, we have a limited time to see patients. And when I have to explain so many because you put me on that situation, that's not gonna be acceptable. So that basically right here, we know. This is the stethoscope. Let's talk about now the instrument that we are going to be using to the heart sounds, to the lung sounds, to the bowel sounds, to the arteries. We can listen to a lot of stuff, but you do not have to do that. You're gonna listen only to the heart sounds if that is what is required, particularly when you're doing blood pressure, because you don't have to do the apical pulse anyways. But if somebody asks you to do it, you can do it. When we get back to the school, I'm gonna show you how it's done, and you're gonna do it to yourself. You're gonna listen to your own heart, and I'm gonna show you how it's done. Or you can listen it to one of your classmates, just for you to know how it's done. Because when your questions on your exam appears over there, if you have done it, it's gonna be a lot easier for you to get the right answer. So that is the reason why sometimes I put my students to practice something, because if you have done it, you did it, you're gonna remember it versus just listening. Okay, so stethoscope. Remember questions for the stethoscope. What is the instrument that is used to listen to the heart sounds or just to listen to sounds? Stethoscope. So that is basically what it is. So it says right here, heartbeat, bowel sounds, lung sounds. It doesn't say the arteries, but we listen to the arteries as well. Parts of the stethoscope. So let's go over the parts of the stethoscope. There are two parts that you need to know from the stethoscope because they're going to ask you. So one of the things that you do, which this nurse that we just watched on the video did, clean the stethoscope, regardless if it is you, the one that is using it, because remember, the stethoscope, we are placing it on somebody else's body, somebody else's skin. It is in contact. So if this stethoscope, I'm going to be using it on someone else without cleaning it, probably I'm going to transmit, I'm going to transport infection from one patient to the next. So that's basically what it is. Because these stethoscopes are personal. These are individual. These are your own stethoscope. This is not the stethoscope that you're going to be using from someone else. Most of us, we have our own stethoscope and we carry it with us all the time and we keep it clean. That's basically what it is. So let's talk about the parts of a stethoscope by just looking at the image. Two parts that are very important right here, but for now, we're just gonna mention them. So here we have the diaphragm. What is the diaphragm? The diaphragm is the broader part, the widest part of the stethoscope. If you look at here at this image, you see that there is one little part right here, and there is one large one on the other end. You, as a medical assistant, you need to use only the diaphragm. When we get back to school, I sound like a broken record all the time, but I have to say it because this is important that you keep, that I keep repeating this thing so it can stick in your heads. The diaphragm is the largest part of a stethoscope. And that's the one that you're going to be using. Because the other part is used by the medical doctor. The medical doctor uses both. But sometimes they use the bell, which is the smallest part here, the bell, because that is to listen the heart sounds and the bruits, which are the artery bruits. So when we have problems listening with the diaphragm, we use the other end, which is the bell. You will not be asked about the bell. You're going to be asked about the diaphragm. What part of the stethoscope you're going to be using to listen to the heart sounds? The diaphragm. It's not asking you about the instrument. It's asking you what part of the stethoscope are you placing on the patient's chest to listening to the heart sounds. The diaphragm. That is the one that you are going to be using. So the other part that you need to know is the earpieces. See the little ends that you're going to be applying inside of the external ear canal, and you have to know how to place it correctly. Believe me, I have many students that they take the earpieces and they place it incorrectly. And what's going to happen? You're never going to hear anything because it has a way of placing those earpieces right there. I will show you how it works. Everything else is just the little tubings and things like that. So not to worry about that. Just know about the diaphragm and the earpieces. Most importantly, the diaphragm, because that's a question for your exam. The earpieces, because you make mistakes when you place them into your ear canals. So if you don't place it correctly, you're not going to hear anything. And at the beginning, listening to the heart sounds is not easy. Now, listening to the heart sounds is not just not easy, but to determining if it is regular or irregular is even harder. But you don't have to do that. You have to do it when you palpate, when you use the radial pulse, if it is regular or irregular. But you will not be asked this question. It's just the basics, the most simple thing. So remember the part of the stethoscope that you're going to be applying to the patient's body to listening to any of the sounds is going to be the diaphragm. That is it. Okay. Any questions about the diaphragm? When we get back to school, I show you other tricks that these stethoscope have, because you can lock your stethoscope. And even though if you place the earpieces correctly and you place the diaphragm correctly, you're not going to hear anything. So I will show you how that works, because you need to be familiar with the stethoscope. It is a very simple instrument, but if you are not familiar with, you can have a little tough time sometimes trying to listen, because you will not listen at all. Okay, any questions about the stethoscope before we move to the next slide? Good. Let's talk about the respiratory rate. Because remember, we're talking about vital signs. We talk about temperature. We talk about the pulse. Now, respiratory rate. Respiratory rate, once again, let me explain you this, because sometimes, we are kind of, we take for granted very simple things. We use lots of acronyms, remember. An acronym is when you use the first letter of a word. So instead of we asking for pulse, we just use the capital E. That means pulse. Respiration rate is RR. So what is the RR of this patient? And immediately said, oh, wait a minute. What do you mean RR? I don't even know what are they talking about? Are they talking about the Long Island Red Roll, something like that? So no, this is the respiratory rate. When we talk about temperature, is T or Fahrenheit. So that's basically what you need to learn, because when you have those questions, they use lots of acronyms. We don't have to spell out every single word. We have some, acronyms that we are allowed to do it. Some of the time they said abbreviations, but these are not abbreviations. But anyways, that's how it's done. So let's start by talking about what is the normal rate of respirations for an adult. Remember, we're talking about adults. Even though if we check in on a child, the questions are going to be for adults. And I'm pretty much focusing most of these lectures directly. I make more emphasis, I repeat more things when it comes to questions for the exam, because you need to pass that national certification. Everything else, you're going to learn it as you go in your workplace, but you're not going to have the opportunity if you don't pass the national certification. So very concerned about that. I know you're going to do it, but still, you just want to make sure that you're not going to miss any of this information. So when we count respiration, remember the normal respiration rate for an adult is between 12 and 20. See? Respirations per minute, RPM. Respirations per minute. N means minute. R respirations. P is respirations per minute, per. So that's basically what it is. So we need to know. The other one is heartbeats per minute. See? Per minute. Heartbeats per minute. When we talk about rate, when we talk about blood pressure. So that's basically how it is. It's like the last name of the measurement. You need to know it, how it's written. Okay, so when we are checking respirations, we are going to count when the chest rises, but there are two things going on. One, inspiration, when you take air in, and the other one when you take air out. We don't count both, we just count one. But breathing in, breathing out is one respiration. But when you check in respirations, you're not gonna go and see, okay, it's breathing in, it's breathing out, breathing in, because you're gonna get confused. Just think about when your chest rises is when you take air in, which is called inhalation, inhalation, breathing in. So you're gonna count that. And if you have a count in between 12 to 20 respirations per minute in an adult, then you have a normal respiration rate. So that's basically what it is. Now, there is something very, very important. Remember, these are questions for exam. The normal respiration rate is 12 to 20 beats per minute for adults. That's it. Remember, you're going to be asked about adults. Every single measurement is going to be about adults. Because babies and schoolers and adolescents and young adults and adults, it changes every single year. Your rates in your parents are changing, so it's very difficult. You're not gonna remember every single thing. So adults state is like an average that you're gonna remember, because it's between this and these numbers. We always gonna document every single procedure, every single vital sign that we check, we need to document it on the patient medical records if we are authorized to do so, or you just write it down in a little, post-it or any paper that you might have there, a little. So that's basically what it is. Do not keep it in your mind. Oh no, I'm gonna remember. No, write it down. To who you took the pulse, blood pressure, temperature, whatever, procedure you have done, record it. Because later on, you're gonna forget. And probably you're gonna get caught up doing something else. You're gonna forget how you're gonna remember exactly what it was. So again, write it down all the time. This is one of these vital signs. Pay attention to this. When you should not tell the patient what is it that you are going to do. Because if you tell the patient that you are going to be checking the respiratory rate or how the patient is breathing, the patient's patterns are going to change because voluntarily the patient can change the pattern of breathing. See, you cannot change anything with my pulse. Yes, I can get very nervous, but my pulse goes up because I don't like the clinics. I don't like the medical doctors. I'm probably very scared because they're going to tell me that I have something because I went there with a problem. That's a different issue. This one is because the patient is going to change the way that they breathe. So think about this. I'm going to be checking your respiratory rate. And if I tell you that I'm going to check your respiratory rate, you're going to change the way that you breathe. It is unconsciously. It's not because you want to. You're going to breathe faster. You're going to be holding your breath. You're going to be doing a lot of things that is not going to allow the technician to do a good job to get an accurate result. Let me give you a little recount of what happens to me. I went to the medical doctor. This medical assistant, I don't know if it was medical, they never introduced themselves. So it was someone over there. It was a technician, nurse, I don't know. They didn't have no badge or anything, no identification. And she said, oh, Mr. Hoyer, I'm going to check your respiratory rate, okay? I'm going to check your pulse. Well, she started doing my respiratory rate and says, wow, how was it? I asked, I know because I was a doctor, that issue, they're going to tell you, even though if you don't ask. But I was trying to prove the point. So I said, how was it? She said, oh, it's normal. And what's normal? She said, oh, it was 18. I said, wow, I'm pretty surprised that you got 18 respirations on me when I was holding my breath all the time. How you did that? So she looked at me and she says, are you a doctor? I said, no, I'm an attorney. I always tell people that I'm an attorney and a very good one. So you see, people should not say anything, not because they're going to do what I did, because I did it on purpose, just to check whether she was getting the results, that she was doing the right thing. No, she just made it up. She didn't see my chest rise or anything else, and she just went and gave me a number. So that's basically what it is. See how things works? But, I prove it when we are in class and you tell that you're going to check respirations, you're going to see how your respiration rate is gonna change. You're going to hold your breath a little bit, then you're going to breathe very fast, and then you can, well, it's going to become a little troublesome right there. So that's basically what it is. So it's very simple. So for this part of the respiration rate, which is easy to do it, what I ask my patients to do is, I want my patients, because let me start from the beginning. When you are going to check the respiratory rate from the patient, forget about telling the patient because you're not gonna tell them. But how are you gonna get an accurate result? Oh, well, sometimes people say, oh, just look at the chest. And when the chest rises, then say 1, rise again, 2, and 3, and you're checking your watch. Or you set it up for a timer for 1 minute or 30 seconds, whatever the case may be. No, that is very hard because sometimes patients have the clothes on. Sometimes the patients do not breathe heavily. You barely see whether the chest is raising or not. So what I recommend my students to do is to ask the patient to cross their hand over their chest, just like I'm doing it right here. Then you're gonna place your hand right here on top of, close to the wrist, on the posterior part of the arm of the patient, and you're gonna apply a little pressure against the chest. Now you're gonna feel when your hand goes up and down, but you're gonna count only when your hand goes up. That's how it's done correctly. Now you're gonna get an accurate result. Because other than that, just checking the chest rising, because that is the question. That's another question that you're gonna have in your exam. How do you know how to count, respirations? Because you're gonna see the chest rise. And every single time the chest rises, you count 1 respiration. Rise, remember, you breathe in and out. That's 1 respiration. But when you breathe out, you're not gonna see it, you're not gonna feel it. But when you take air, you're gonna see it. Because remember, you are taking air normally without forcing yourself. It's not that you're gonna ask the patient, okay, start breathing heavily. Breathe out, breathe. No, that's not how it is. The patient doesn't know. You're just checking how many breaths per minute the patient is having. So you place the patient's hand. Do not place your hand, hold the patient's hand. No, you're gonna ask them to do it themselves, and then you put your hand right here at the tip of your fingers against the hand, and then you're gonna feel when it goes up. When it goes up, 1, 2, 3, until you have the time that you have selected to count. That's basically what it is. So it's very important, again, that you understand this. Remember, questions for the exam, you should not tell the patient that you're going to check vital signs because the patient's respiratory pattern changes and you're not going to get accurate results. Okay. And the other question is, what is the normal respiratory rate? Remember, it's 12 to 20 respirations per minute. Any questions before we watch a little video so you can see how it's done? I'm not pretty sure if this is a video. I haven't seen these videos for a long time. So, see, I'm not gonna be able to remember every single thing. So let me get this video first. And okay, I'm gonna watch the video with you. So let's see if it has any flaws or it is just how I want it. Remember, for the purpose of the exam, I want you to get the right thing, not because you watch a video and if it's wrong done, then you're gonna pick the answer that is wrong. No, I don't want any of those. Okay, here's the video.
To assess a patient's respiration, first check for factors that can affect respiration, such as exercise, anxiety, acute pain, smoking, and medication.
Great. Okay, well, what I'm going to do is I'm going to raise your bed and then raise your head, and then I'm going to check your respiratory rate. Okay, sir? I'm going to have you learn on your back for me.
Help the patient into a comfortable position, preferably sitting or lying with the head of the bed elevated 45 to 60 degrees.
See that the semi-forward position?
Make sure his chest is visible, moving the bed linen or gown as needed.
Just relax for me.
Next, place his arm in a relaxed position across his lower chest or upper abdomen as you would to assess his pulse. Or simply place your hand directly over his lower chest or upper abdomen. Observe a complete respiratory cycle of 1 inspiration and 1 expiration. Then, look at your watch. When the second hand reaches a number on the dial, or when the digital display reaches a round number, begin taking the respiratory rate, counting 1 with the full respiratory cycle. If the respiratory rhythm is regular, count it for 30 seconds and multiply the number of breaths by 2. The respiratory rate normally ranges from 12 to 20 breaths per minute. If the respiratory rhythm is irregular, or less than 12 or more than 20 breaths per minute, count the breaths for a full 60 seconds. As you count the rate, note the depth of the respiration by observing movement of the chest wall, or do this after counting the rate by palpating chest wall excursion or auscultating the posterior thorax. Describe the depth as shallow, normal, or deep. Also note the respiratory rhythm, which should be regular and uninterrupted, except for an occasional sigh. Observe for dyspnea and ask the patient to compare any shortness of breath to his usual breathing pattern. Adjust the patient's bed linen as necessary and discuss your findings with him.
Mr. Williams, have you had any breathing problems? No. Okay. Well, your respiratory rate, your breathing rate was 16, which is within the normal range.
Okay. So the video tell you, yeah, let me go back to. So the video tell you a lot of information. The narrator is telling you a lot of stuff, but you don't need to know every single detail about the respiration is set for the respiration rate and how the hand or the arm of the patient is placed over the chest and your hand as a technician over the patient's arm. So that is about correct. Everything else, remember, you do not give information to the patient because you're not the doctor. The only one who discusses things with the patients are doctors. Anyone else, just do the procedure, go document it, get the information to the doctor. That is it. Remember that all these questions about whether, they're having problems breathing, whether they have this or that, they can make. No, you just do the procedure. That is it. You do the blood pressure, you do the pulse, you do the temperature. That is it. You need to know what is the reason the patient is there, because not precisely in this case, because this patient is admitted and we have to do vital signs every day. But for an outpatient, remember, you don't go over all this information at all, unless you are the doctor and you are examining the patient directly yourself, then you will deliver all that information. Anyone else shouldn't be telling any of those. Any questions about how to check the respiratory rate? Most of the information was there. Remember, 12 to 20 breaths per minute or respirations per minute. That means the same. So that basically what it is. Now you're going to count for 1 minute, remember. Pulse, you count for 1 minute. Respiration rate, you count for 1 minute. Temperature depends on the device that you're using. Or if it is the one glass, you're going to leave it for 3 to 5 minutes. That's a different issue. But once again, some of the vital signs, you need to count for a minute. But remember, if the breathing looks like it is regular, then you count for 30 seconds and multiply it by 2. So rhythm that is regular means that the patient is going, the chest is racing almost at the same time as the second breath and the third breath. It's like the beats. So that is what's considered regular. But if the patient is breathing very fast, well, that's not regular. So definitely it's not. So again, but there are many things, that they went over. You don't need to know all that. Just the simple part right here. That's how it is. So normal respiratory rate for normal respiratory rates, adults. So young and middle age, 60 to 20 respirations per minute. Older adults, 14 to 16 respirations per minute. Remember, these are kind of populations in different ranges. This is not what you're going to be asked, but it's just information that is there. Okay, so don't get confused. It is 12 to 20 respirations or breaths per minute. That is it. For children, the children usually breathes faster. Why? Because the lungs are very small. So they try to catch up with oxygen by breathing faster. So that's basically what it is. But we're not going to go over that once again. If you have to do the respiration for the children, the only thing that you have to do is check the respirations. That is it. Whatever numbers are, you're going to record it, give it to the pediatrician. That's it. They're going to deal with that. You don't have to. Nobody's going to ask you. The medical provider is not going to tell you. So what do you think, Mr. Hoyer? Is this respiratory rate for this child at this age normal or abnormal? What do you think? No, they're not going to ask you questions. You just give them the information and that's it. They decide what to do over there with their patients. We're just there to assist the medical providers. We don't need to get involved in any details. Less is more. People listen to me because other than that, remember, that can get you in trouble. Blood pressure. Now, once again, blood pressure is one of the vital signs that takes a little more to learn it. Believe me, vital signs, particularly blood pressure, it takes longer. You do not learn how to check blood pressure in 5 or 10 minutes. You do not. So it's going to take longer than that. So for that reason, this we will practice more. The other ones that can be done in 5 minutes. I'm telling you, in 5 minutes, 10 minutes maximum, you can learn how to check pulse, how to check the respiratory rate. This is very simple. And to check temperature. But blood pressure takes a little longer than that. It's a little more complex. Because now you have to listen to the heart sounds. And listening to the heart sounds when you are not placing the stethoscope directly over the heart, it's going to be hard. Because you have to place it on the brachial artery, on the patient's arm. So the pulses over there are fainted, so meaning they are not strong enough. And a little noise, a little manipulation of the diaphragm over the patient's skin can produce some noises that you're not going to be able to recognize the heartbeat, because something else, some artifacts are going to be causing interruption and you're not going to know what you're doing. So once again, you need to learn the blood pressure cuff size, because one size do not fit all. So we have blood pressure cuffs that are pediatric, small, medium, large, extra large. If you don't use the appropriate size, cuff size, you're going to get wrong results. 100%. So that's basically what you need to understand. Now, when we talk about blood pressure's definition is a little kind of actually hard to understand as well. But when we talk about blood pressure, the definition usually is the force that the blood ejects against the walls of the arteries as it passes through. So when we apply the blood pressure cuff on your arm, we are trying kind of blocking that brachial artery. As the blood try to pass through these arteries that are kind of half blocked, you know, you're gonna hear that sound because the blood is kind of going against the walls of the artery, and that causes the pressure. Remember, this is like when you apply pressure over the radial artery. So you're kind of blocking the radial artery, trying to prevent that the blood passes because you're pushing against. So that's when the blood tries to pass through this vein, then you feel like, you know, lifting your finger because you are applying pressure against it. And blood tries to pass through. And when it tries to pass through, try to lift your fingers. And that's when you feel the heart beating. Well, listening to the heart sounds are totally different than feeling the artery because it's a lot easier with your fingers versus your ears. So for that reason, taking, learning how to do blood pressure takes a little more time. You're gonna get it, oh, definitely. But it's not, in 5 minutes or 10 minutes. You gotta work a little more than that. So that's basically what it is. Now, blood pressure is written as a fraction. It says right here. What's a fraction? One number that is, below another number. It can be written like this. It can be written like this. You can use either or. So that's how it works. And these are millimeters of mercury. Just like here. So once again, learn this because these are questions for exam. How the blood pressure is measured. Millimeters of mercury. That's how it's measured. Now, the top number, remember, this is a fraction. The top number is called systolic, and the lower number is called diastolic, just like right here. Systolic, diastolic. Systolic means contraction. So when your chambers in your heart contracts to push the blood out of the heart, send it to the head, to the arms, to all the organs, to the foot, that is called contraction. It's squeezing, pumping. So that is the largest number, which is on top. That will be the systolic contraction. Now, 60 is when the heart will not pumping. When the heart relaxes, I just already pump blood through all the structures of the body. Now, start filling in with blood again to pump again. Because that's what the function of the heart does. Because the heart is a pump. Blood enters the heart pumps the blood out, then it's empty, right? Now start filling in. That filling in process is the diastolic relaxation. When the heart starts relaxing, because it's not pumping, it is called diastolic. Again, we're going to go over this in more detail when we get to EKG. Because that is the part that we're going to be discussing this again. But you already have idea when we talk about this. Remember, this is going to come very handy later on. That's what these procedures and these chapters kind of correlates to each other. It's not like totally independent chapters. They are connected. Somehow they are connected because our body is connected. All the systems are connected. So if one system fails, the other systems start failing. because all of them works as a part of the team in conjunction. If it's one part fails, then everything else starts getting weaker. And eventually everything is going to collapse if it's not fixed. So that's basically what it is. This is the blood pressure. Most of the time, they do not ask about the definition. Remember, the definition of blood pressure is the force, the pressure, then the force that the blood ejects against the wall of the artery as it passes through causes blood pressure. That's basically how it is. Remember that we are going to place a sphygmomanometer, which is the instrument that we usually call blood pressure cuff, that we're gonna roll it up right under, over the upper arm. And then we're gonna start pumping, filling it with air so we can block the blood vessel. So we're gonna learn all that because that is what blood pressure is all about. And it takes a little more time because how do you know how far you're gonna be filling in the blood pressure cuff with air or pumping? Well, you don't know until I explain it to you if you have not taken this class before. So that's basically what it is, because those are questions for exam. You need to know how far you can go filling in the blood pressure cuff with air. How much pressure, how much can I squeeze the patient arm? Well, it has to be squeezed as much as just trying to block a little bit the blood pressure, the arteries. But we're gonna learn that with facts. It's not like I'm gonna guess how far I'm gonna go. No, we're gonna see how that's gonna work. Remember, blood pressure is a little more difficult to learn than any other vital signs. The other vital signs are kind of very simple, easy. But blood pressure is a different technique and a different procedure that takes a little more. Let's talk about ranges of blood pressure. Once again, we have here for children, because it is based on age, remember. But we're not gonna be going crazy about blood pressure for the pediatric population, because you will not be asked. Whatever numbers you get, as long as you learn how to do it right, that's what you are going to document, but you don't have to explain. Whereas for adults, you need to know what is considered normal. The American Heart Association has been changing all these ranges frequently. So we need to make sure that we have, the policies of our organization has the latest American Heart Association guidelines to do this. So that's basically what it is. So it says right here, which I'm not agree with a lot, because that's not how it works. It says right here, normal, less than 120. Well, it's not like that. So now do not worry about these values. That the systolic, the highest number, needs to be below 120 to be considered normal. So according to the textbook, but things have changed? No, it's not like that. So no worries for now, just going over. The diastolic says right here, less than 80. Well, it's not like that either. It has to be less than 90. This one has to be less than 130. So that's basically what it is. Here they put in like a perfect kind of blood pressure. But remember, blood pressure is not one single number. We always use ranges. See, it's there right here, pressure ranges in between this and that. See, you can have in between 12 to 20 respirations per minute. So you have 13, normal, 14, normal, 15, 16, 17, up to 20, normal. So it's not just one number. It's not like 18. That's if you don't have 18, if you have more than 18, less than 18, not good. No, it doesn't work that way. We have ranges for almost everything in medicine. That's what we check ranges from ages. Depends on your age, this group, this age, from this age to this age. Now we're going to have these values because it changes according to the age. But the values also changes. The value changes depends of the institution that you're working in. They don't change much, but they have little differences. The values change depends on the laboratory that you're using that is going to analyze your body fluids. We have little differences, but they fall within what is considered normal. So that's basically what it is. So it says right here, pre-hypertension, 120 to 139. That is not true either. Because if you have 120 is normal. 125, 124 is normal. 126 is normal. 128 is normal because it's 130. Anything above 130, now it is considered that something is going on with it. So that's basically what it is. So just for the purpose of the exam, think about these. These are the ranges that will be based your exam and the ranges that I use when applying to medicine. So 130, anything below 130, that's the systolic. Oh my God. And here, anything below 89. Anything below 89 is fine. So if I'm 100 and remember numbers, values collected from blood pressure needs to be even numbers. There is no odd numbers. Oh, here I have odd number. It's 88. Oops, my bad. So it has to be even numbers. It is 120, 130, 128, 136, but you cannot have 127, 77. No, doesn't work in blood pressure. So if you mark something like this, immediately I know you don't know what you're doing. Because that's basically what it is. Because the aneroid, that little clock like structure from the blood pressure cuff, it's like a little clock, looks like, that is called an aneroid. It marks with a little needle numbers by twos. So once again, it has to be even numbers, not odd numbers. So whenever you get the answers in an exam, check. If you see uneven numbers for blood pressure, that's not the right answer. Pick the one that has an even answer. And you don't even need to know the answer. Actually, it's just knowing how this works. So that's basically how it is. So for blood pressure, do not worry too much about the ranges, okay? Because it is very variable. Yes, we have some numbers, but don't. Now, one of the things that you do need to know is that if they give you a number, it's going to be a large number. Let's say, for instance, the patient's blood pressure is 200 over 100. So oh my goodness, that's more than 130. That's what I saw. So this person is in trouble. But what we use instead is pulse. So remember, pulse You need to know because it's 60 to 100. Here we have different values, different averages. Let the doctor interpret this. Because remember, there are many factors that can, change your temperature, your pulse rate, your respiration rate, your blood pressure. So we don't get involved in any of those. But the good thing about respiratory rate is because you have a range for adults, 60 to 100 beats per minute. So those are the questions that they're going to ask you. Remember, we don't go to the pediatrics because it changes. Here in blood pressure is the same. Now, what you need to know is what happens if the blood pressure is above normal ranges. You have hypertension. What about your blood pressure goes below normal ranges? They're going to tell you like that. They're not going to say below this number. No. Then you're going to know, that is hypotension. So you just have to find out the definition and the term that is used to represent that definition. That is basically what it is. If the patient has a very high blood pressure, how you call that? Hypertension. You check in the blood pressure of the patient, and the patient blood pressure is very low. What is called? Hypotension. Those are the things that you need to understand. Not to learn all these values, because these values do not are not for you. This is for medical doctors only. Remember, I'm giving you the ranges that you will be asked because they are straightforward. What is the normal respiratory rate for adults? 12 to 20. That's basically what it is. But for this part, we're just going to leave it like this. So that's basically with this part. Let's take a break, and when we come back, we continue giving you more information about blood pressure. This is the last part of this chapter. And then we have another chapter that we're going to start and continue with the module to the end of this week. So that's basically what it is. Any questions before we go on break? Okay. So let's, come back at 7:40. Enjoy your break. See you then.
Okay.
Thank you. Okay, we are back. I hope you guys enjoy your break. Let's continue with this chapter. Almost done.
Yeah.
Thank you. Okay, so we left off right here what is considered normal ranges for the blood pressure. But once again, do not focus much on these values for now. When we get to practice this, I will explain you certain things that you need to know when you actually practicing, not for the purpose of the exam. So that's basically what it is. So once again, blood pressure has a little more details to cover. So we will move on with this. Let's talk about factors that can influence blood pressure measurements. So once again, lots of things can change the values, or let's put it this way, some factors independent to, the person itself, or just the values that we could consider normal, that we can understand, what is exactly going on with blood pressure. That's the reason that I told you that we're not going to have some numbers there as an average. We're going to have a group of numbers later on when we get the chance to practice this, so you can understand this better, how to perform blood pressure, because there are different situations in which your blood pressure can change and becomes the norm, or change temporarily. So gender is one of those factors that can change the values of blood pressure. So remember, blood pressure sounds like very straightforward when we have those average written on paper, but actually it doesn't work that way. It's not like the pulse that is straightforward. We have certain numbers. It's not like, respiration rate that we have some numbers. It's not like the temperature, you just place the temperature, but still the temperature can change based on certain factors. So we have to just understand the situation. So for that reason, I don't want you to memorize numbers for blood pressure, because that will be of no use for now. So learn just the basics, how to correctly check the blood pressure. Let the doctor decide. That is it. Because there were no questions from this part for your exam, because it's a very complex subject. And there is no one kind of short definition for it. So gender, age, remember little kids they have a different blood pressure than younger adults, than adults and elderly patients. As we grow up, blood pressure tends to go down. Oh, I was talking about gender. What am I talking about? I'm talking about age. Okay, I'm looking about age. My bad. But well, I just went. So as we age, temperature tends to go down. It doesn't go up. It goes up if you have a problem called hypertension. If you have hypertension, now you are going to have, your blood pressure higher than normal, regardless of your age. But in normal circumstances, your blood pressure should go down. Gender. Males usually tends to have more high blood pressure than females. So again, males tends more to suffer of high blood pressure than females. So gender is important. Ethnicity. Ethnicity means your race. Afro-Americans tends to have problems with high blood pressure more than Caucasians and Hispanic. So when we have a Afro-American person coming to our office and we check the blood pressure and the blood pressure is high, kind of, you can understand, says, oh, okay, yeah. Afro-Americans tends to have high blood pressure. They develop high blood pressure from younger age. So those are the things that we usually learn. Diet and exercise. Think about this. Diet, how's diet affected? Well, if you eat too much salty stuff and you have too much sodium, because sodium is one of those elements that causes your blood pressure to go high because your heart beats faster with the presence of sodium, as we will discuss when we get to electrocardiography. So think about this. If you know someone who has hypertension or you have hypertension yourself or a friend, you heard about that, the first thing that they tell you is like, hey, your diet has to be low in sodium. Because that's basically what it is, because sodium causes and other things too, but sodium particularly can increase your blood pressure. Medications. See, one of the side effects of some medications is, they help you with the problem, but then they increase your blood pressure on the other side or on the other end. Remember, medications are good, but medications also have side effects. And those side effects can be increasing your blood pressure or decreasing your blood pressure. Either or in this case. Sodium increases is definitely. Ethnicity, if you're an Afro-American, increases. Your age, remember, as you grow older, it decreases. Gender, males tends to have more problems with high blood pressure than females. While medications do its part as well. So every single time that someone is taking medications, you gotta ask, what are the possible side effects? Remember, when the medical doctor prescribes you medication, it's because the medical doctor has already weighed it out. So which one is worse, the medication or the side effects? Is this going to fix the problem or it's going to create more problems in the long run? Well, no, the medication is going to do well for the problem that you have right now, but one of the side effects is that can cause this. So at the meantime, if you develop hypertension, now we're going to give you medications for hypertension too, because the medications are causing you that. Or the medical doctor needs to change the medication. So that's basically what it is. So medications, there are some medications that cause your blood pressure to go high or down, either or. Another thing that I mentioned before, emotional situations or emotional turmoil. Remember, when you are upset, your blood pressure is high. But here is the difference, that you do not have high blood pressure. It is caused by your emotional situation on that particular time. So should I give you medications for hypertension? Definitely not. I have to fix the emotional problem, which is causing you high blood pressure to go high, not because you have problems with hypertension. So you don't. Remember, if you are upset, if you are angry, if you are sad, you lost your job, you lost a loved one, you're sick, they give you bad diagnosis, that's going to increase your blood pressure, your pulse. Those two comes hand to hand. So you got to understand this, because if we don't understand this, remember, you as a medical assistant, once again, you're going to be telling the patient that they have high blood pressure or that they have low blood pressure without considering all these factors. And once again, it's not our job to tell the patient results. That's the doctor's job. So that's basically what it is. Even though if it sounds very, very harmless, oh no, it's normal, blah, blah, blah. No, don't. Just refrain yourself, because you're gonna get used to, and if it is high, you're gonna tell them. If it is normal, you're gonna tell them. If it's low, you're gonna tell them. So don't say anything at all. Position. Well, depends of your body position. Now, this is not that you're gonna have hypertension. Remember, these are factors that influences blood pressure, or can put it above normal ranges, below normal ranges. It's not that you're gonna have hypertension. It's not that because of this, you're gonna develop hypertension. No, it's the factors that can change your blood pressure at that particular moment. And if you do not take in consideration these situations, then you're gonna think that this person has a problem with blood pressure. That is my point. It's not like, oh, gender, you're gonna have high blood pressure because, oh, just because you are this, you are male. No, certain people tends to have more. Now, position, once again, this is about when we are checking the blood pressure. If I check your blood pressure standing, and then I change you the position to a sitting position, and then I change you the position to laying down position, these blood pressures are going to be different because of the position that you have. Some of the patients, sometimes they develop something that is called positional hypertension or hypotension. So some people, they are standing or laying down on a bed, and as soon as they change the position, they feel like they're gonna fall, that they're gonna faint. Everything start kind of going around, and this is not very good. It's just that it happens. A sudden movement of your body or head or bending suddenly or turning around can make you dizzy. That is positional hypotension. So in medicine, we check the patient's blood pressure sitting down, standing up, and laying down, because we need to compare the different values to see, if you have a medical condition or not. Last but not least, smoking and alcohol. See, smoking increases your blood pressure because nicotine, like caffeine, oh, that's another one from diet, increases your blood pressure. So if it increases your blood pressure, it's because your heart beats faster. That's what caffeine and nicotine does. Alcohol, on the other hand, is a downer. So if you drink alcohol, your heart is not going to be fast. It's going to be low. That's what some people, oh, no, I'm very nervous. I'm going to smoke something to calm myself down. Ain't working. Doesn't happen that way. Or others use alcohol to relax themselves. See that when you drink alcohol, because I have long time ago, not anymore. When I was younger, I got a couple of drinks and I end up in the hospital. Finito. That's it. Not drinking anymore. It makes you relax. It's an inhibitor. If you feel like you're kind of timid, kind of not outspoken, like introvert, and you drink, now who you are the party person. It doesn't increase your heart rate. It relaxes, because when you are nervous, increases it. This is like when you go for an interview, or the doctor call you that they need to see you to give you the results. That is urgent. Oh, wait a minute. That sounds like not good news. So my heart starts racing, isn't it? So that's how it works. So there are many things that change, how your heart beats. And these are the things that you have to take in consideration as a medical assistant. So when the patient comes in, remember, first of all, exercise. If you do exercise while you're running and you're walking, your blood pressure is going to increase. So when the patient comes into the office, as I mentioned yesterday, they're walking. They're coming from somewhere, from the train station, from the bus station, from the parking lot. Even though if it is just parked right there, the time that they move from the car, from the outside of the street to the medical office, and if they see that the medical office is packed, they're going to get anxious. Oh, it's going to take too long. Oh, now the whole, situation change. And if you stand in front of the counter and you're not taking care of the patient immediately, now I get very upset. Some people already are upset. So remember, all these are part of factors that can alter your results. So you ask the patients to sit at least 10 to 15 minutes before you check vital signs. Remember, we talk about temperature, respiratory rate. All these are altered by all these factors. And once again, if you don't follow them, then you're going to get inaccurate results. It's not being a efficient medical assistant. Oh my God, I'm excellent. Patient is right here. Just enter. Oh my God, I'm putting it back there to do vital signs. I need to roll the ball right here. No, that's not how it works. Give it time. Make sure that the patients are relaxed before you take in this. And if still they are relaxed, then they have other issues. Remember, it might be medications. They already have the condition. People don't stop smoking just because you tell them. People don't stop drinking alcohol just because you tell them. Even though if you tell them that that's going to kill them, hey, goes from one ear to the next. I'm talking about medical providers. I have explained patients how bad it is. They don't listen. But these are the causes of conditions. Remember, if you stop smoking, your blood pressure goes back to normal ranges. If that was the reason. If you stop taking alcohol, same thing. If you follow a diet, it's exactly the same. Well, I'm not going to tell you not to get nervous, not to get upset, but this is temporary. So these factors, you must take them into account when you are, collecting these vital signs from your patients. We're not talking about measurements. Doesn't affect measurement. Doesn't affect diet effects. But, the other vital signs is definitely going to change, because this is our, the health status of the patient that we're talking about. Okay, any questions about this? Now, before we move, let's dip into something that might have questions for exam when we talk about gender and age and ethnicity. Think about this. So ethnicity, age, gender are situations that you cannot change. You change your gender. Well, please do not tell me that. I'm not talking about that. You might want it to be like, it's not going to change your gender anyways. Can you change your age? Well, it's not that I'm gonna lie about it. No, these are things that you cannot control. So for the exam purposes, now that I'm here, because I just recall this, when you are asked which of the following are considered control or uncontrolled factors that influences vital signs, whether blood pressure, respiration rate, or pulse, particularly pulse, respiration rate, and blood pressure. Gender, age, ethnicity. This is not something that you can control. You male, you're male. You are Afro-American, you're Caucasian, you are Hispanic. You cannot change that. How can you change that? So there are certain things that you cannot change. So whenever they give you a question, when they ask you which of the following is considered something that it is uncontrollable, you cannot control, you cannot change. Gender, age, ethnicity. Diet, can you change? Can you control? Yes. What about exercise? Also, I can do exercise if I need it. I can stop doing exercise. These are things that you can control or you cannot control. Medications, can you control medications? Of course, we can change your medication. You can stop taking the medication. Emotional, can you control that? Yes. You fix the problem, or, you accept that, something is going on. That is temporary, it's changes. Your position, can you control that? Definitely. Can you control smoking? Definitely. Can you control alcohol? Definitely. I'm not saying that it's easy that you're going to control this overnight, but can be controlled? Yes. But no matter how you do it, you cannot control your gender, your age, and your ethnicity. Because these are factors that cannot be controlled. So whenever you have a question, when they ask you about these factors or these situations in which you cannot control them, remember, gender, age, ethnicity. So basically, that's what it is. Remember, gender means you cannot control your sex. And we're not going to go to the streams, okay? So this is something, even though if you are transgender, naturally, you are not that other person. Is that understood? Physiological, if you were a woman and you transgender to female, you still just a male and a female, it's the same. So just in case you're thinking about that. So no. Physiologically, you're still a male, you're still a female, nothing changed. It's your mind, the one that changed. The way that you perceive yourself, but it has nothing to do with vital signs. I'm just clarifying that. Okay, so these are uncontrollable factors. Remember, anything else can be controlled, but this. Okay, so let's talk about the procedure actually for measure the blood pressure. The only way we're gonna learn blood pressure, remember, is by doing it directly, and we're gonna practice. So the first thing that we're gonna go over is what is the name of the instrument that we are going to use to check blood pressure, because it's a question for your exam. So here it is. Use an aneroid. Forget about the aneroid. It's called a sphygmomanometer. That's it. Easy, right? Well, you're gonna know because this word is so difficult to pronounce. Oh my God, not to mention to spell it out. But a sphygmomanometer is that blood pressure cuff that we put around the patient's arm to check the blood pressure. So be careful with this question because they're gonna ask you which of the following instruments are gonna be used to check blood pressure. And then you're gonna look for sphygmomanometer. That's straightforward. They're not going to ask you anything else. So that's basically what it is. Now, things that you have to do when you're going to check the blood pressure after greeting your patient, identifying yourself, your position, identifying the patient, telling the patient what you're going to do, then you are going to place the patient on a quiet room. What is that? Because if you don't do that, and if you have noise in the surrounding area, you're not going to be able to hear or to listen in their heartbeats. That is it. When you become very good at it, when you have a lot of practice, it doesn't matter. This is when we used these stethoscopes to listen to the heart sounds, when we do it manually. I know some of you are thinking, well, nowadays, they have an automated or digital vital signs machine. Yeah, but that's not going to be part of the test. The part of the test is this. So these are the things that you have to take in consideration, because if you don't follow this, then you're not going to be able to listen to the heart sounds. You're going to be learning this very fast, because when you're in the classroom, people is talking next to you while you're trying to capture listening to the heart sound, you're going to understand better. So we're always going to bring the patients to a separate area if we're going to do a procedure, because we're going to be, we're going to first of all render these patients privacy. That's number one. Number two, the constraints of, being in the waiting area or somewhere else checking the blood pressure. Unless you're going to do it using the automated systems. That will be different. But because it's not like that we're going to learn how to do it manually, then that's how it is. Second, proper cuff size. Remember, as I mentioned before we went to break, we are going to have a pediatric blood pressure cuff, very tiny. It looks like, for checking, playing around, like, with the doll, because this is a very, very tiny. Small, like for me, because my arms are not that big. Medium for someone who has their arms a little, larger. Large and extra large. Now, pay attention what is written next. Never apply the cuff or the sphygmomanometer over the clothes, which is something that 90% of the technicians, nurses, medical doctors do. You're not going to have an accurate results when you do that. The arm needs to be completely uncovered. Oh no, this is a very tiny sweater. You can put, no. You have to roll up your sleeve, and if it doesn't roll up, no worries. I give you a gown. Just uncover that arm. I'm telling you, you're not doing the right thing if you do that. And it happens. I've been in the doctor's office with my mom, myself, my little kids when they were little enough. They don't get sick later. And they do it that way. They just place it on top. Once the medical doctor wanted to put the blood pressure cuff right on top of my mom's sweater. And on top of that, she has a blouse and all the stuff. I said, oh, seriously? You're not going to be able to do it right. So that's basically what it is. Now, things that you also need to remember is if you have any issues in those particular arms, you should not use it at all. For instance, you have a cast on your hand. or on your lower arm. Oh, no, but it's on the lower arm, it's in the hand. No worries, I'm gonna put it on the upper arm. No, negative. You complain about pain either arm. If you complain about pain about the left arm, do not check blood pressure over there, please. Take the other arm. If you have a shunt is a port that is used and left on place when someone gets dialysis. What are you going to be placing blood pressure cuff when you have a shunt that you can damage, that you can block, even though if it is not in that place, but you are constricting the blood vessels, those ones that are going to bring blood and going to be drained through that shunt, or the one that you're going to be receiving fluids, medications, because you are hospitalized. If you have an IV line on that particular arm, hand, you should not place a blood pressure cuff either. You are constricting the blood vessels. How the medication is going to go? You're going to create infiltration. Now, all the medication is going to stay on the arm, and you're going to get a swollen arm this big. So again, if the patient tells you, please use this arm, that's what you're going to do. But sometimes, you know, we just think that we can control the whole circus, and we just tell them, oh, this arm. No. Sometimes the patient tells you, oh, no, do this arm. Oh, no, I'm closest to this one. No, listening to the patient. Why? Because sometimes this is another issue. Mastectomy. First of all, for those who do not know what is mastectomy, or those who forgot what mastectomy is when the patient has females, we're talking about females here, when the breast from the female has been removed. So if a female has the right breast removed, you should never use the right arm to do any vital signs. Nothing. Not even drawing blood. Nothing. You should not do no procedures from that side. If the patient has bilateral mastectomy, what is bilateral mastectomy? Both breasts have been removed. You cannot use either arm. Let the doctor do that. Remember, during the exam, they just gonna try to see whether you know what it is. The medical doctor is not gonna ask you to do blood pressure on a patient who has bilateral mastectomy. They have other means. They're gonna check blood pressure somewhere else. So you don't do it. But for the purpose of the exams, they wanna see whether you know what you're doing. So that's basically what it is. So don't take it literally that, oh, if the patient is this and then I have to learn all this and I have to remember all this. No, most of the time the patient comes in, you don't know anything. And you're going to tell the patient, oh, I'm going to be drawing your blood, the doctor ordered. The patient says, sure, not a problem. Oh, just, they're going to say from this arm, they're going to just raise the arm that they want you. Even though if you see a nice blood vessel on the other side, don't insist. They probably have a mastectomy, and this is not something that you're going to be sharing with everyone. So probably they don't want to tell you. But if they said, no, just do it from here, that's it. No questions asked. Otherwise, check the medical record of the patient. Check the requisition form. The requisition form says, diagnosis, patient has right breast mastectomy, left breast mastectomy, or bilateral mastectomy. So that's basically what it is. So you have to check it out. So for blood pressure, anything that is going to probably compromise blood vessels and lymph nodes, you're not going to cause, because you're going to cause damage to the patient's arm. Serious damage. So you don't want that. So that's how it works. So be careful every single time that you're going to do something. You know, just that's what you're going to tell the patient what you're going to do. So the patient knows if, they kind of gonna refuse or they give you other options. That's how it works. Here are some of the blood pressure sizes. Remember, this is the pediatric one, the little one on the bottom. This one is the pediatric. This one is like medium, remember? Oh, small, my bad. There is another medium. I don't have all of them. This is medium. Oops, it was medium. Remember, this is small, medium. There is a large and extra large. Remember, we have people who has very, very large arms. So what happens if I use a blood pressure cuff that is too small for the patient's arms? The blood pressure is going to be higher than normal, even though the blood pressure is normal. So a small cuff causes the blood pressure to increase. Think about this. What about if you use a larger cuff for a small arm? The opposite. Now you're going to be taking the blood pressure, and the blood pressure is going to show that it's low than actually is. Learn this because these are very important. Remember, what happens? You do the medical assistant, you doing a blood pressure, and you using a smaller blood pressure cuff compared to the arm. What will be the results? Higher. You have a big arm, you have a small, so you're going to tighten up very fast. That is if the actual blood pressure cuff can go around. So a small cuff causes blood pressure to go higher, remember. And a large cuff causes your blood pressure to go lower. Don't forget this for your exam, because this is the way it is. That's why we have different cuff sizes. So you can use the appropriate cuff size for the patient. So that's how it is. You look your arms. I know I'm small. If I have someone that is almost the same size on my arm, I use the small one. If I have someone whose arm is a little larger than mine, medium. If it is larger, kind of larger, double than mine, large. And if it is extremely large, then, hey, we're going to do the extra large. Because it has consequences. Remember, false positive, false negative results. So once again, if the blood pressure cuff is small compared to the size of the arm, the results are going to be higher than normal. It's like the opposite. You use something smaller, it's going to increase. You use something very large. Think about this. It's very large, and I have a very tiny arm. You blowing and blowing and blowing there. That blood cuff is not going to have enough pressure or air inside to constrict my blood vessels because it's too large. It's not going to do the job. The opposite also works. Too small, as soon as you start pumping, that blood pressure is about to blow, to detach. So immediately you're gonna get blood pressure high. So know those definitions because very important for you to know it. Any questions? No worries, I will give you these questions on your exam so you can remember. They are not here on the slides, but I will give it to you. Okay, so there are two ways of checking blood pressure. So we talk about one using the sphygmomanometer and the stethoscope. So you're gonna listen to the heart beats. But there is another process or procedure that is called blood pressure by palpation. Yes. We're going to use the technique using the blood pressure cuff, the sphygmomagnometer, but we're not going to use the stethoscope. We're going to use our fingers and we're going to use the radial pulse. This is a lot easier. One of the problems with this blood pressure is that you're only going to get the systolic, not the diastolic. Because remember, the systolic is when you have the highest contraction number. As you pumping all the way up, we'll go over all that in practice. So this is going to be by palpation. So you need to know this for the exam. So when you're doing the palpation method, remember, palpation is to touch. So now I'm not going to use the stethoscope. What I'm going to use is my fingers. So that's basically what it is. So what is the purpose of doing this? I don't get it. It's only when I check the systolic. It's a lot easier when you start doing the systolic pressure because you're going to learn how far you can go when you're using your stethoscope, how far you can inflate the blood pressure cuff on that particular patient. So that's basically what it is. Remember, systolic is the higher number on the fraction. Here, we're only going to get the fraction, the systolic, the larger number, not the small number. Why? Because you cannot get it. I understand you're kind of confused. I don't blame you. Because this is not easy. Remember that I told you it's a little more complex. Blood pressure is more complex than anything else. And the only way to get this done is by doing it. Just reading it, going over the steps and the guidelines, and you're not going to get it. I'm telling you. But this part of the blood pressure by palpation or getting the systolic blood pressure by palpation is a lot easier because you're going to feel it just like when you were checking the pulse. So what we do is we're going to apply the blood pressure cuff just like you were going to do the regular blood pressure checkup using your stethoscope. It's just that you're not going to do it. So you're going to apply the blood pressure cuff and then you are going to locate the radial pulse. Remember that we're going to use the radial pulse for that. So you're going to go apply the blood pressure cuff. Do not inflate it yet because it works in combination with your fingers. Now you're going to place your fingers on the radial pulse. Now you're going to start inflating the blood pressure cuff. Remember that you are the technician, so you're going to have two hands. One, you're going to be pumping the blood pressure cuff. With the other one, you're going to place your fingers on the patient radial pulse. So you're going to go easy. Remember, every 30 milligrams of millimeters of mercury. I will show you when we get there because once again, it has a lot of stuff that you need to learn from the equipment that we're going to use. We just talked about the size of the blood pressure cuff, but we didn't talk about the aneroid. We didn't talk about the bulb that you're going to be compressing. You're not going to be talking about the little device that opens and closes to allow air goes in and then to lock it in. The valve. So we need to talk about that. And the aneroid, how are you going to measure it? How are you going to read it? How do you know how far you can go after? So that's basically what it is. Now that you did that, now you're going to close the valve of the blood pressure cuff or the sphygmomagnometer. You're going to close it because remember, it's going to be open first. So all the air is out from the blood pressure cuff. The blood pressure cuff should not have any air. It has to be in zero, has to be balanced. Now, for those who have not taken vital signs with me or with anyone else and done the procedure, no worries. I told you from the beginning, blood pressure, it is more complex. It's not impossible. It's not something that, oh, no, you're not going to be able to do it. No, you're going to be able to. Oh, my goodness, if I did it, I did it myself. So if I did it, anybody can do it. It's just that it takes a little more time, and the time means practicing. That's the only time you can learn this. Here, by just saying this, or by just showing you video, you're not gonna learn. You can learn respiratory rate, you can learn pulse, you can learn pain management, you can learn how to do the temperature. But just watching videos, you can do it. But blood pressure, you have to actually do it. Practice. Be involved, get to know the equipment that you're gonna use. If you don't, you're gonna be lost because you're gonna be like having loopholes, like kind of gaps. Okay, I know how to do this, but this is how it works. So for that reason, we need to practice and we need to do it. So you're going to inflate the blood pressure cuff as you press in the fingers and keep it there. So you remember when we check the pulse, as soon as you put your fingers, you're gonna find the pulse. So at this time, well, we're not gonna look for the pulse. We're gonna look for when the pulse disappears. So you place the finger right there on the radial pulse, and you start inflating the bomb with the bulb of the blood pressure cuff. Start inflating with the other finger. Remember, you have two hands. You are the one who's doing it. So one with the bulb of the blood pressure cuff. The other one hand is with the fingers over the radial pulse. So you start inflating every 30 millimeters of mercury. You pump, relax a little bit. Oh, I still feel it. Pump, relax. Oh, I still feel it. Pump, still feel it. It's gonna be the moment when you pump, you don't feel the pulse anymore. It vanishes. You don't feel it anymore in your fingers. So this is the time that you have to go 30 millimeters of mercury above the time that you don't feel it, that you lost the pulse. Now you release the valve, so you start deflating the blood pressure cuff very slowly. Because if you open the valve too fast, it deflates from one and the blood pressure goes down and you don't capture anything. So that's basically what it is. So as you come down, you're gonna be waiting for that gap where you saw that the blood pressure stopped, but you didn't feel it anymore, the pulsation, because that's where you go 30, 30, 30. Oh, I lost it right here in between 120 and 100 and 120, or 120 and 130. I lost it. So it's gonna be there, but what number is it? So I'm going 150, and then I release it, and when it goes back down very slowly, you're gonna start feeling the pulsations in your finger. That is the systolic. So that's how it works. Once again, we're gonna do it because that's the only way to learn it. And that's how you're gonna record an accurate blood pressure by palpation. So remember, by palpation, you only are gonna find the systolic, and you're not gonna use stethoscope. You're gonna use your fingers because you're gonna check the radial pulse, not the brachial pulse, as if you were using the stethoscope. So once again, don't pay too much mind for this in the lecture because we're gonna go over this, and when we start doing practically, then you're gonna get what is exactly. This is a lot easier, the one for palpation versus the one that you're gonna be using the stethoscope. This one you're gonna learn a lot easier what is it that you're gonna do, particularly how far you are going to go, how far are you going to inflate the blood pressure cuff. We do not have a number when we are asked, okay, so how do you know how far you're gonna go inflating the blood pressure cuff to check the blood pressure? We don't know. Each patient is different because each patient has a different blood pressure. So there is no number. There is no 160, there is no 200, there is no 120, there's no numbers. You just need to do it by every 30 millimeters of mercury as you are inflating, you're listening or you're feeling it. When you don't listen anymore, the beats, now you're gonna go 30 millimeters of mercury above that aneroid dial, and then you release the valve, the air start coming out, you deflate the blood pressure cuff. Now when the needle start going down very little, very slow, now you're gonna capture where the heart sounds are or where, you know, the pulsations on your fingers are, depends on which type of method you're using. So that's basically how it works. So let's watch this video for this one, just for you to have an idea. Not the one that we do with the stethoscope, I believe. I believe that's not the one. This is by palpation. And remember, these are questions for exam as well. The method of palpation. Oh, wait a minute, it was here. Okay, yeah. This is by palpation, so yeah. This is the one. Okay, so just follow the video. Do not stress yourself out. Oh my God, I missed this. What's going on? No, just check what they're doing, see what they're doing, and then, you know, you compare with the things that I told you. But the only way that we're gonna do this and you're gonna learn is by doing it, remember.
This is how you palpate blood pressure. The reason for palpating blood pressure is primarily because you cannot hear or auscultate for a blood pressure. Sometimes in the back of a noisy ambulance, this is impossible to do. So this is one way we can at least get a portion of the blood pressure. The only thing this will represent, though, is the systolic. We will not get a diastolic during this procedure. First, locate the radial pulse. Making sure your patient is in a comfortable seated position. Expose the arm. Place this blood pressure cuff, again, over the brachial artery. Feel for a pulse again, a radial pulse. As I pump it up, I will continue to feel it, and at the point where it goes away, I'll add about 20 or 30 millimeters of mercury, and then slowly allow the air to release. At the time the pulse returns, there is my systolic, and I'm done. This is only going to give me the top number or the systolic. And the way you'll represent this on your documentation is to put whatever number the systolic is, we'll say 120 over a P to indicate this is by palpation.
Very simple, see? But only doing it, you can understand it. Now, this, because it's by palpation, is a lot easier because you already did the radial pulse. Now it's applying the blood pressure cuff. But the problem is inflating the blood pressure cuff. What is the 30 millimeters of mercury? And because this guy is a professional, you know, it's a EMT or probably paramedic, looks like, and they go like fast because they know what they're doing. You are not gonna do that. We are going to go very slow because you're gonna, you know, pump or apply pressure over the valve of the blood pressure cuff to inflate the cuff slowly. We do once, then you're gonna see that goes like 30 millimeters of mercury. This is like a clock, and you're gonna be seeing there, or a watch, the aneroid, and you're gonna see how far it goes every 30, and then you stop because you're learning it. Now, when you become good, that's what you're gonna do. See, this person says sometimes it's very difficult to get blood pressure because it's a lot of noise, because of the job that they do. They work in an ambulance. All these sounds, see the sounds of the siren going on when you bring in the patient to the hospital. You're not gonna be able to hear it. And all the people screaming inside, and sometimes even members of family goes there, and other people, pass me this, get me an IV line, do the CPR. Well, hello, it's gonna be really hard. Remember, when we want to do these vital signs, what is the first thing that we're going to do? We're going to bring them to a quiet room because we're not going to be able to hear anything. So in order for them to do at least part of the procedure, the palpatory blood pressure comes handy because you can do it by palpating. You don't need to hear anything. You just use your fingers, use your eyes to check the aneroid and to see how far it goes and what is the systolic pressure. So that's how it works. And you're going to see that it's a lot easier when we start, because the first thing that we're going to do is we're going to start with the palpatory or the palpation blood pressure. And then we're going to move to the next one because you have an idea. It's like giving you half of the training. So when you go to do with using the stethoscope, you're gonna learn the second half. Just the blood pressure cuff, how to manipulate, how to maneuver the blood pressure cuff, you know it. Now is how to listen to through the stethoscope. So that's how it works, okay? So don't panic, my students, that you're gonna be really good at it. So. Where I am. Okay. Okay, so we are done with this chapter, so we are going to move to the next chapter. We're going to start. So tomorrow we're going to have less for the lecture. Remember, tomorrow we have a class. So please make sure that, you know, this is not going to be every Friday. This is just one exception. Due to the fact that Monday is a holiday, and well, we don't want to take Monday holiday, we're gonna take it off, and we're gonna do Friday instead. Okay, so this next chapter, which is the last chapter, is minor office surgical procedures. So this is important because you're gonna have questions for your exam again. And just in case you need to assist the medical doctor doing some of the procedures, at least you know how to fix that procedure room. At least you know how to do it, because that is basic. So before we do the procedure, remember, it's going to be a preoperative instructions to the patient. Those instructions needs to be verbally and written instructions. Always. You're not going to ask or tell the patient that you're going to do procedure just by talking to them. Sometimes they need to prepare prior to the procedure. This is not like the patient comes in and he has a cut or a nosebleed and you're going to send them home to prepare themselves and then come back. No, this is a different situation. So if a patient has a procedure that has to be done, usually it is scheduled. So you are going to, the patient is going to have time for the procedure. So we are going to give you all the instructions. First explain, then remember the medical doctor explained them. But we need to reinforce this information because the medical doctor is not giving them the written instructions. We are as medical assistants. So as soon as the patient is going to be discharged, we know already that the patient is going to have a procedure. So we are going to go over the procedures again, all the steps from the guidelines, from the written guidelines that we're going to give the patient. And once again, those guidelines needs to be in the language that the patient speaks. What is the purpose of you giving me something in Greek when I don't speak Greek, or Hindi when I don't speak Hindi, or Chinese if I don't speak Chinese? So you have to give the patient, the instructions in the language that you speak. And if you do not speak the language of the patient, you have to have a translator. Basically, that's what it is. Remember, we discussed this in, the administrative part, which is communication with the patients, which some of you have not gone through it, but see, we go back again to the same things because we are repeating, using it in different scenarios. If the patient has any doubts about the procedure or any step or any of the instructions, we have to go over it. You should not get upset. Oh, well, listen, you have the instructions right there. Read it. No, you have to clarify anything before the patient leaves the office. And if you cannot do it, you get someone else who knows how to do it, or tell the medical doctor to go over. Because that's how it is. Remember, use plain language. Use the language that your patient is going to understand. Do not use medical jargon, medical terminology. It's a no. You're always going to ask the patient if they have any questions. You explain everything, the patient agrees that everything is okay. Still, do you have any other questions for me, Mr. or Mrs. Smith? No, thank you. Okay, so have a wonderful day. Have a great night. See you next time. If you have any questions, please, our office hours, because you're going to give them a reminder card. So the patients are not done just because you told them something. Still a lot of things you have to do, particularly those patients that has to prepare for a surgical procedure. This is minor surgical procedures. So some of the things that the patient might have to do, this is what pertains to us as medical assistants. Areas of preoperative instructions. So for the patients, most of the time, you're going to tell them, the patient might have to fast. Fasting has to be between 8 to 12 hours prior to the procedure. Should not take anything by mouth, which is NPO. So learn these acronyms. NPO means nothing by mouth, which actually means nothing per mouth, nothing per oral, because this is Latin. So that's basically what it is. So NPO, nothing by mouth. So that basic meaning you should not be eating anything or drinking anything 8 to 12 hours prior to procedure. Sometimes the patient might have to stop some medication. That's not your job. But it is your job to reinforce to the patient because the medical doctor gave you instructions and you are going to tell the patient, Mr. and Mrs. Smith, remember, don't forget, you need to stop this medication. They are written right here. Remember, you have to stop 7 days before, prior, 2 days prior, 24 hours prior. Tell them exactly what is written right there. Remember that when the doctor is talking to the patient is so nervous because they're going to go to this procedure. They are more worried about the procedure than the instructions that the doctor gave them. So the medical doctor sends the patient to talk to us because we need to go over this. That is the reason. So that's basically what it is. If there is some restrictions for some reason, the restrictions are going to be there when the doctor gives the order. So you have to tell the patient. Remember, do not eat this, stop this, don't do exercise. Don't take this particular, don't take over-the-counter medications. Don't take any home remedies. Tell them whatever the medical doctor explained right there. So that's basically what it is. It doesn't matter what test it's going to be. So those are the most common things that you are going to be telling them, reminding them, because it's going to be written in the orders that the medical gave the patient. So you're just going to go over them. The patient, the medical doctor has gone over already. You're just reviewing them, reinforcing this information. Because if you don't, the patient is going to start calling you every single day into the office. Oh, they gave me this paper. What is this paper for? I know your attitude right now. So again, you might be busy, you might be doing something, and the patient is calling for every single question. Oh, I have to do the test tomorrow. What is it that I have to do prior? Well, you were supposed to stop taking the medication 7 days ago. There's no time now. So now your medical procedure is going to be delayed, needs to be rescheduled. See how many things can happen when we're not giving clear explanations to the patient. And even though if you give clear explanations, still the patient, sometimes do not comply. But that's not your problem anymore because you already gave them what they need. So that's basically what it is. Another thing that you have to make sure, we went over this already, so we're not going to spend too much time talking about this. Informed consent. Remember that the person that gives the informed consent is not the medical assistant, is not the nurse, it's the medical doctor. If I'm ordering a procedure for you, I'm the one who has to go over this consent. I'm the one who is supposed to ask the patient to sign in front of me in a witness. Not relay this to the medical assistant or delegate this to someone else. Patient needs to understand exactly what procedure is going to be, where it's going to be done, what are the risks, what are the benefits. There's other options. So that's basically what it is. Remember, the patient has the right to refuse. The patient has the right to know what's going to happen. So that is the part of the legal and the ethical aspects that you have to follow. So we went over the consent, remember, we know this. We kind of, again, touch bases because every single time that you're going to do a procedure, because it's minor surgical procedure or a surgical procedure, an informed consent needs to be signed. To draw blood, I don't need to sign a consent. To do an EKG, I don't need to consent you. To do vital signs, I don't need to consent. You don't have to sign anything. I'm just telling you because you are going to give me an implied consent. Yes, no, or you just agree with. But for these type of procedures, when the risk of the person can be at stake, we are going to have an informed consent. That's why we go over these things, because first of all, it is needed. What you have to do as a medical assistant is not go over all this, because that's not your job, is to make sure that you have the informed consent there on the medical record that the patient has signed it. Because you weren't there probably when the medical doctor signed it. Because when the patient comes back, you have to have the consent there when they're going to do the procedure again. You can't say, oh, I don't know what the consent is at. I don't know. I wasn't there. I didn't see it. No, we have to see that the consent is there. Otherwise, you cannot do the procedure. The procedure is canceled. Because now you have to consent the patient again, and the patient needs to go and come back. Not good. This is the consent form. Remember, this is all the explanation, everything that's going to be done, who's going to be doing it, the risk, the benefits needs to be written in this document. Remember that we went over this during law and ethics. We're going to go over these procedures all the time. So when we get, for those who has not taken this part of the consent in detail, when we get to the to that module, you're gonna see it. For those who you took it, well, this is a reinforcing information. Because these are 100% questions for your exam. They're gonna ask you, what is an informed consent? There is no doubt. For that reason, we go over and over and over from things. We talked about this not long ago when we talk about infection control, medical and surgical sepsis. So remember things that you need just to know it, because one of the key points right here is when we talk about medical sepsis, remember this is not eliminating all the microorganisms. Sometimes we're not even eliminating them. We're just inhibiting them. We're just removing them from the site when we're gonna do the procedure. And then after the procedure and we clean the chemicals that we put in the area where the incision, the procedure is gonna be done. And when we clean it, these pathogens come back there to these microorganisms, they come back to that site again. Because remember, that's the normal flora. So remember, during medical sepsis, we just want to use regular gloves, medical gloves, not surgical gloves. On the other hand, surgical sepsis, remember, always, because these are questions for exam, surgical sepsis, during this process, all the microorganisms, all, including the spores, are eliminated. During medical sepsis, no. Some of the microorganisms might be eliminated, but some others don't. They stay alive. Here, we are going to eliminate all of them. That's what's called an sterile technique, because everything has to be sterile. There is no contamination. That's basically what it is. So here, we're going to use everything that is going to be sterile for this process. Medical sepsis, we don't need sterile field. But for the surgical sepsis, yes. For the medical sepsis, we're just going to wash our hands regularly with soap and water. For the surgical sepsis, it's not going to be like that. We're going to scrub our hands, arms, from the elbows down for 5 to 10 minutes. The other one is 15 to 20 seconds. See all the differences? So you can read this part of the medical sepsis versus surgical sepsis, but I already mentioned. The most important thing is that surgical sepsis, remember, eliminates all the microorganisms. Think about the autoclave when we were sterilizing instruments, is to eliminate everything, including spores, which are these microorganisms that are super protected because they have double layer of the covering surface. Those are eliminated. During medical sepsis, no, this is just very simple procedure. Because we are not going invasive. We're not going to go inside the patient. We're not cutting everything and going inside the patient's body. So if you're going to go inside the patient's body, most definitely you need to use a surgical sepsis. So that's how it works. So again, how are we going to prepare the site where the medical doctor is going to do the procedure? So we got to get familiar with the area. We got to make sure that we know what we're doing. Once again, if you know the procedure, if you've been trained, of course. But we are giving you here the basics. So the medical assistant prepares the surgical area, provides sterile equipment, instruments, and supply. Whatever is needed, we need to gather the supplies and prepare the sterile field. So we're going to eliminate all the microorganisms in the surrounding area where we are going to be performing the procedures, particularly when we are going to be placing the instruments, the supplies. That can be in a medical office, that can be in a surgical center, whether ambulatory or inpatients. It doesn't matter. if you are going to assist during a procedure where we are going to cut down or something is going to go inside the patient, we got to do some, you got to do the surgical asepsis. You must, because this is where the risks are very prone to happen if you don't follow these sterile procedures, which means asepsis. Guidelines for preventing contamination. Well, say no more. Remember, we mentioned this. We're going to wash our hands. But this time is not just washing with soap and water. Remember, we're going to wash our hands surgically. And this is called surgically scrub or just scrub. Then we're going to use, after that, this is a process, we're going to use sterile gloves. When we are in front of the field, the hands, have you seen videos or television shows, whatever the case may be, with the medical doctors usually walk like this with the hands up? Well, that's the way it is. Because remember, when we do the hand washing, the regular hand washing, we keep the fingers down. But we only wash our hands from the waist to the tip of the fingers with soap and water. That's the medical sepsis. But when we do the scrub, we're going to scrub from the upper arm all the way down to the elbow to the fingertips. But every single time that we do that, we're going to keep our hands like this. We're scrubbing. So we want the water and the contaminants run to the elbow, not to the fingertips. So that's basically what it is. And when you're done and you have your gloves on, you walk like this. You should not be touching anything. Anything below the waist is contaminated. So the waist up, sterile, the waist down. So that's the reason why you keep your hands like this. Maybe you never asked yourself, what is these people walking like this after they scrub their hands or their arms? Because you should not lower your hands. You cannot go down because then they are contaminated. Remember, anything that goes below the waist is contaminated. So if you put your hands down below the waist, you're contaminated. You have to go scrub again. You have to go glove again, put your gown again, and everything has to be sterile. You should not leave the sterile area for no reason and come back like nothing happened. Oh, I live with all this and I come back. No, as soon as you walk out of that room, you have to start all over again if you were supposed to continue with the surgical procedure. Medical doctors enter the surgical room, the OR, or the ambulatory surgical room and stay there until they'll finish. When they finish, now they can move out and start removing all these garbage. You should keep movements to the minimum. You're not going around and rubbing against somebody else because as soon as you touch someone else, contaminated. Not talking. You should not be talking because remember, droplets comes from your mouth, even though if you have a mask, but you have your patient right there and it's open. Something might fall off. Who knows? These are droplets. These are very little, can go through the mask because we're breathing and we're talking. And when we talk, we have facial muscle movement. So the mask can be kind of move a little bit or something is going to happen. You don't want to put yourself into that situation. Of course, it's got to be very hard because I have never been in a surgical, well, let me rephrase it. I never did a surgical procedure myself because I'm not a surgical doctor. But when I was doing my residency and I was assisting because we have to, I assist during procedures like appendectomy. We did C-sections. those are the serious things that I did because I didn't want to get involved into surgical. I never liked surgical. So can you imagine wanting to sneeze? How you stop that? Cough, how you stop that? So you're gonna minimize things to do that. But sometimes, if you're sick and if you're sneezing, if you're coughing, you're definitely not gonna be in the OR. You're not gonna be in a surgical procedure. Not as a medical assistant, not as a nurse, not as a medical doctor. So that's basically what it is. Two things that you need to know from this slide before we go sleep, I guess. This one, yesterday. Tomorrow we'll go over when we see